Sometimes we're not ourselves. There's no one I can turn to. And I know all the feelings that we shared are in the past. And I know your relationships are never meant to last. And I'll take some time, but I'll be alright. Moving on, moving on. I know times are
Ladies and gentlemen, the National Autoimmune Day will be commenced shortly. Kindly put your mobile phones on silent for the smooth running event. Before we begin, here are some housekeeping announcements. Number 1, restrooms are located outside to the left of this auditorium, near the lift. Number 2, morning and afternoon refreshment will be served over at Cafeteria Sehat Level 5. Number 3, lunch will also be served over at Cafeteria Sehat Level 5. And for our Muslim guests and participants, prayer rooms are located at Level 3. Assalamualaikum and a very good morning to Dr. Masita Arif, Head of the Allergy and Immunology Research Center, Institute for Medical Research IMR, distinguished guests, speakers, participants, ladies and gentlemen. Welcome to the National Autoimmune Day 2025, co-organized by the Malaysian Immunology Interest Group from the Malaysian Society of Infectious Diseases and Chemotherapy. My name is Dr. Shuwahida, and together with me, my partner, Puan Nurhanani, will be your MC for today's event. It is a privilege to be standing here today amongst a wonderful gathering of experts in the field of autoimmunity. The National Autoimmune Day serves as a platform to raise awareness and foster collaboration in the field of autoimmunity. Each year, it highlights a key autoimmune condition, and this year's focus on myositis, a group of rare inflammatory muscle diseases that are often underdiagnosed and not well understood. Today, we are honored to have with us distinguished speakers who will be sharing on topics relating to myositis, an exciting frontier in autoimmunity research and diagnostic. We hope today's event will offer unique insight into muscle inflammation mechanism and paving the way for innovative therapeutic strategies. To begin our day, I would like to invite Mr. Muhammad Haikal to the stage for a doa recitation. Thank you.
Al-Fatiha. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين وعلى آله وصحبه أجمعين. Ya Allah, Tuhan yang Maha Pengasih lagi Maha Penyayang, kami bersyukur atas limpahan rahmat dan nikmat-Mu kerana dengan izin-Mu jua kami dapat berhimpun dalam Majlis Nasional Autoimmune Day 2025 pada hari yang penuh bermakna ini. Kurniakanlah keberkatan kepada majlis ini, Ya Allah. Jadikanlah ia medan untuk menimba ilmu, bertukar pandangan dan memperkukuh kerjasama antara para penyelidik, pakar dan warga kesihatan demi kesejahteraan pesakit dan kemajuan sains perubatan negara. Ya Allah, permudahkanlah perjalanan program ini dari awal hingga akhir. Lindungilah kami dari sebarang kesulitan dan limpahkanlah keberkatan serta rahmat-Mu kepada kami semua. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzaban nar. Wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi wa sallam walhamdulillahi rabbil alamin.
Thank you, Encik Muhammad Haikal. Honorable guests, ladies and gentlemen, it is great pleasure to invite Dr. Masita Arif, Head of the Allergy and Immunology Research Center, Institute for Medical Research IMR, and co-chair of the National Autoimmune Day 2025 to deliver her welcoming speech. Let's give Dr. Masita Arif a warm welcome.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, distinguished guests, esteemed speakers and valued participants. It is my great honor to welcome all of you to the National Autoimmune Day 2025, an event proudly organized by the Autoimmune Unit of the Allergy and Immunology Research Center, AIRC, Institute for Medical Research. This annual gathering serves as a vital platform to raise awareness and foster a deeper understanding of autoimmune diseases in Malaysia. And this year, we turn our focus to a particularly challenging and often overlooked condition, myositis. Myositis refers to a group of rare inflammatory muscle diseases that remain underdiagnosed and poorly understood, not only among the general public, but also within the healthcare community. These conditions can be debilitating, affecting patients' mobility, quality of life, and overall health outcomes. By dedicating today's program to myositis, we aim to shed light on its complexities, improve diagnostic accuracy, and enhance clinical management strategies. This one-day seminar brings together a diverse and dynamic group of professionals, clinicians, laboratory scientists, researchers, and allied health experts from across the country. It is a unique opportunity to exchange knowledge, share experiences, and explore the latest advancement in autoimmune diagnostics and care. We are privileged to host expert speakers from various disciplines, including pathology, rheumatology, immunology, and industry partners, each contributing valuable insights into the evolving landscape of myositis research and treatment. Throughout the day, participants will gain a comprehensive understanding of the role of autoantibodies in diagnosing myositis, laboratory testing strategies and real-world case applications, clinical challenges and treatment considerations, emerging technologies in autoimmune diagnostics, and ongoing research and future direction in myositis care. Beyond the scientific and clinical discussions, this event also serves a broader purpose to strengthen our national network of healthcare professionals committed to autoimmune disease care. By fostering collaboration and encouraging multidisciplinary dialogue, we hope to inspire new research initiatives, improve patient advocacy, and ultimately drive better outcomes for those affected by these complex conditions. I would like also to have a sincere thank you to the organizing committee led by Dr. Siti Fatimah. Where's Dr. Siti Fatimah? Okay. Your dedication, meticulous planning, and tireless efforts behind the scenes have truly paid off. From the initial concept to the final execution, your commitment to excellence has been evident in every detail, and this seminar has not only been informative but also inspiring, and that is a testament to your hard work. I would also like to extend my deepest appreciation to our collaborators, the Malaysian Society of Infectious Disease Chemotherapy, or MSIDC, Immunology Interest Group. Your support, expertise, and partnership have added immense value to this seminar. Whether through insightful contribution, logistical support, and simply your presence, you have helped elevate this event to new heights. Together, we have created a space for learning, dialogue, and connection, and it is through such collaboration that we continue to grow as a community and as professionals. Let today be a catalyst for progress. Let it spark new ideas, challenge existing paradigms, and reinforce our shared commitment to advancing autoimmune disease care in Malaysia. Whether you are here to learn, to teach, or to connect, your presence is a testament to the growing momentum in this field and the collective effort to make a meaningful difference. On behalf of the organizing committee, I thank you for joining us and wish you a productive, insightful, and inspiring National Autoimmune Day 2025. Thank you.
Thank you, Dr. Masita. Okay, ladies and gentlemen, we will begin our seminar today with the first talk entitled Roles of Autoantibodies in Myositis, that will be delivered by Associate Professor Dr. Asrul Abdul Wahab from University Kebangsaan Malaysia. Dr. Asrul is an Associate Professor at the Department of Medical Microbiology and Immunology, Faculty of Medicine UKM, and currently serves as a head of department as well as head of the Immunology Unit at Hospital Chancellor Tuanku Mukris UKM. Its ongoing research focuses on autoimmune diagnostic, infectious diseases, and the development of improved laboratory testing methods for better disease detection and management. Without further ado, please welcome Dr. Asrul to deliver her presentation. Thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good morning. Thank you, Chairperson, for nice introduction. So it's a pleasure to be the first speaker for this event. Dr. Anis said just now he's nervous. So I will start the nervousness. Okay, basically, thank you, Dr. Siti Fatimah, for inviting me for this event. I would like to congratulate the organizing committee to make this event successful. Okay, to all the participants. So as Dr. Masita said just now, so this is our challenge actually to educate or to create awareness for this rare disease, the idiopathic. Last time we call this as idiopathic inflammatory myositis. Okay, so it's a group of diseases. As you can see, I will share with you after this the progress of the disease. Okay, from the initial criteria in 1975, so until now, right? So this is the topic given to me, the roles of autoantibodies in myositis. So this is the place where I work actually, okay? So this is not very sharp, but this is the Faculty of Medicine UKM in Cheras. So we have different blocks actually. So initially, at the moment actually I work in many places, okay? So one of those places is this Hospital Chancellor Tuanku Mohris. So we have our diagnostic lab at the basement level, okay? So you can see at the basement level. So not like here upstairs, so we are at the basement, right? Okay, so but it's a very nice laboratories. So now in 2014, so we have a new building here, the preclinical building. So my department is located at this building, preclinical building. So this is the preclinical building. So behind you can see the Hospital Chancellor Tuanku Mohris. So this building is 18-story building. So level 18 here is the anatomy department. 17 is pharmacology. So our department is here at level 16. So the lecturer's room is on this side. So we have the KL town panoramic view actually. Okay. All right. So I have to see like this because we don't have the monitor here. So this is the outline of my presentation. So I will start a little bit on introduction, epidemiology, clinical features, myositis autoantibodies, little bit on the laboratory aspect because Dr. Anis will cover on the challenges and also on for the laboratory aspects. So then I go to the topic for today, role of these autoantibodies. So just a little bit on introduction. So idiopathic inflammatory myositis is a group of autoimmune diseases. So mainly it is characterized by the proximal muscle weakness, right? Skin disease and also internal organ involvement. So one of the important internal organ involvement is the esophagus, because some of these patients can present with dysphagia, means that there is some difficulty in swallowing because it involves the skeletal muscle in the esophagus. Okay. So in terms of the subtypes, we have different subtypes that include the polymyositis, dermatomyositis, inclusion body myositis, and also we have another subtype which is known as the overlap syndrome, okay, overlap myositis. So in terms of the epidemiology, seriously, we don't have the global epidemiology. So this is the result that when I asked the ChatGPT, so this is what given by the ChatGPT. So we have the prevalence around 2.4 to 33.8 per 100,000, with projected annual incidence of the maybe around 1 to 19 new cases per year, okay, per million population, right? So still, actually, this condition is underreported in many regions, including in Southeast Asia. Of course, we don't have the data for our country. So this is probably the challenge that we need to answer. To have I will suggest that maybe nationwide study, not the retrospective, we should do prospective rather than retrospective. Because if we do retrospective, some of data may be missed, okay? So maybe we can look into this later on. Maybe Dr. Siti Fatimah can take the lead after this. So in terms of the clinical features, so these are the 4 main clinical features that include the muscle weakness, cutaneous features, pulmonary, and also arthritis. So muscle weakness, usually it involves the proximal muscle, okay? And of course, it involves mainly the skeletal muscles, okay? Cutaneous features, so there are different cutaneous features that has been described, okay? There are different rashes, okay? That heliotrope rash and so on, okay? Pulmonary, so some of the patients, they can develop pulmonary symptoms either as a complication or they develop this as their initial presentation, okay? So very closely related to these pulmonary symptoms, mainly is the interstitial lung disease, okay? So most of the patients, some of the patients in the subtypes, so they develop into this interstitial lung disease. So some of the patients also develop arthritis, especially those that belong to the overlap myositis. So they have associated disease like SLE, scleroderma, and so on. So they present mainly with arthritis. Okay. So this example of the published cases. Just want to highlight on the clinical presentation. So in this case, like 61-year-old male. So he presented with a 3-week history of progressive generalized weakness and dysphagia of solid. So basically, all this just to highlight on the involvement of the muscle. So muscle weakness, dysphagia, so involvement of the muscles. And it involves, so this is a typical features, proximal upper limbs. And most of the time, they are symmetrical, okay? Symmetrical. So this is case of the polymyositis actually. So the second case is a 54-year-old female. So she presented with this hyperpigmented erythematous rash. And also she developed this progress symptoms like muscle pain. And case 3 is again a generalized weakness, shortness of breath, and she had this heliotrope rash, which is the rash that involved the eyelids associated with periorbital edema. Okay, so this is the heliotrope rash involving at the periorbital area, always associated with periorbital edema. So this patient also developed what we call this interstitial lung disease, evidenced by the HRCT. Okay. So now I come to the myositis antibodies. So we have 2 types or 2 big groups of the myositis antibodies. One is known as the myositis specific antibodies or MSA, and the other one is myositis associated antibodies. So all these are the myositis specific antibodies. You have these anti-synthetase antibodies, a very big group. Okay, so many autoantibodies belong to this group, anti-synthetase antibodies, anti-HMG-CR, and then you have the anti-SRP, TIF, SAE, ME, NSP, MDA5, and CN1A. So I put the asterisk for the CN1A because this is a little bit controversial for these autoantibodies. Initially, they found that these antibodies are specific to the myositis, but later on, from the recent studies, these autoantibodies can also be found in other conditions like SLE, systemic sclerosis. Okay, so that makes it less specific for myositis. So these are the myositis associated antibodies. So you have this RNP, Rho, PMSCL, and Cu. Okay. So now I will talk about the anti-synthesis antibodies. All right. So anti-synthesis antibodies, perhaps these are the most common, okay, most common phenotypes, most common antibodies found in myositis patients. Okay. So collectively, these autoantibodies contribute to the development of a syndrome that known as the anti-synthesis syndrome. Okay. So we can divide the autoantibodies, anti-synthesis antibodies into Jo1 and non-Jo1. Okay. So because I think the initial one is the Jo1, subsequently they found many other anti-synthesis autoantibodies. Right. So the non-Jo1 include the PL7, PL17, ZO, HA, KS, OJ, and EJ. Okay. Okay, so basically these autoantibodies, they target the amino acid RNA synthesis. Okay, so as mentioned earlier, so this is quite common, detected around 35 to 40% of patients with myositis. So the anti-synthesis syndrome, so patient will present like this. So they have this interstitial lung disease. Okay, so they can have Raynaud's phenomena, mechanics hand, not only hand, they can also have mechanics foot, okay, arthritis, and also skin rash. So anti-Jo1 antibodies. So this is, as you can see that for the anti-synthesis antibodies, so they have different targets of the on the amino acid RNA transferase synthesis. Okay, so the Jo1s actually target this anti-histidine or target this histidine tRNA synthesis. So this is the first anti-synthesis antibodies discovered. So in 1980. Okay, so perhaps this is the most common autoantibodies associated with the myositis. So the clinical features will be ILD, interstitial lung disease. So this occur in about more than 30% of the patients. So they can have mechanics hand, Raynaud's phenomena, which can precede myositis in some cases, and myositis and also arthritis. So in terms of the prognosis, it is said that these Jo1 antibodies associated with better prognosis than non-Jo1 anti-synthesis antibodies. So non-Jo1 antibodies, so frequency is around maybe 1 to 5% for each subtypes. And anti-PL12 is actually very rare, but can overlap with systemic sclerosis, and they are more likely to have dysphagia. Okay, so ILD has been described in PL7, PL12, OJ, and KS. Some reports suggest that KS, anti-KS, may be associated with more severe ILD. Okay, and some can also present with rash, but the rash is very non-classical. Like in dermatomyositis, the rashes are quite classical. Okay. So this to highlight on the different targets of the anti-synthesis antibodies. Okay. So for example, just now I mentioned about the Jo1, so they target this histidine. PL7, threonine, so different amino acids has been targeted. Okay. So this is the frequency. You can see that Jo1 is around 15 to 20%, okay, followed by PL7, 5 to 10%, EJ around 5 to 10%, others little bit less, okay. So these autoantibodies, when you do anti-nuclear antibody test, they can have positive cytoplasmic pattern, okay, because this tRNA synthesis located in the cytoplasmic of the nucleus of the cell. Okay. So collectively, they contribute to this anti-synthesis syndrome. So now, anti-HMG-CR. So this target the 3-hydroxyl 3-methylglutaryl CoA reductase. So this is the enzyme important for the cholesterol limiting step of the cholesterol synthesis. So this is the target for the statin. So when we prescribe, doctors prescribe statin to the patient, so it targets this enzyme actually. So this certain HLA increase the risk of this development of the anti-HMG-CR. So statin exposure has been found in around 40 to 60% of the overall cases of the IMNM. So IMNM is the immune-mediated necrotizing myositis or myopathies. Okay. Some studies showed around 92% exposure to statin, especially among adults more than 50 years. However, weaker association was found in French study and also Japanese studies. In terms of the clinical, this patient can present with more insidious onset of muscle weakness. So we have a local study in Malaysia about the immune-mediated necrotizing myopathy or myositis. The study conducted by University Malaya Group. Okay, so they found there is no patient with the positive anti-HMG-CR. None of the patient actually on statin. Okay, so means that in terms of the correlation with statin is still controversial. Okay, not really definitive. So now anti-SRP antibodies. So again, they target the protein, signal recognition protein. This is located in the cytoplasm. So it occurs in 4% in Caucasian polymyositis, dermatomyositis, 13% in the Chinese studies, Chinese group of the IIM from China, 10.5% from African studies. So again, there are certain HLA that maybe correlate with the development of the anti-SRP. In terms of the clinical presentation, so this similar to anti-HMG-CR actually, because they belong to the same group, they cause the immune-mediated necrotizing myopathies. So this antibodies is very rare in children. So these are the two antibodies that cause this condition known as immune-mediated necrotizing myopathy, anti-HMG-CR and anti-SRP. So mainly these antibodies located at the endoplasmic reticulum of the cell. Okay, anti-SRP can be found in the cytoplasm as well. So now I go to the dermatomyositis antibodies. So you have first is the anti-Me2 antibodies. So basically, Me2 is very crucial for the epidermal remodeling. So that's why this patient you can see they can present mainly with the rash. Okay, frequency is around 11 to 59% of the adult dermatomyositis, and 4 to 10% of juvenile dermatomyositis. So in terms of the clinical presentation, they can have classical cutaneous features. The good thing about the Me2 positive patients is that they have lower rate of interstitial lung disease and also lower rate of the malignancy association. Anti-SAE antibodies, okay, so this is around 2.6% of the Euromyositis registry, very rare in North American cohort. In terms of the clinical, most will have a cutaneous rash typical of dermatomyositis, very mild muscle weakness, can be subclinical as well. ALD also very rare in these antibodies, but the main thing is that they are very closely linked to dysphagia. So most of these patients, you can see that 78% of the SAE positive dermatomyositis will present with dysphagia, compared to 43% in SAE negative patients actually. So initial report actually there is no link with the malignancy, but recent study suggested that maybe around 10% of the patient, 10% risk of cancer associated myositis. Okay. Now we move to the TIF, anti-TIF1 antibodies. So this is very important for the many cellular pathways actually, this antigen or this protein. Okay. So basically, in terms of the frequency, it's about 7 to 31% of adult DM, dermatomyositis, 22 to 32% of the juvenile groups. The main thing about these antibodies, it is strongly associated with the cancer. Okay. So two groups of adult TIF. So you can divide into two groups basically. So first is those that are less than 40 years old. So clinically, they will have this amyopathic with low risk of malignancy. And those that 40 and above, so they can have myopathy, increase in myopathy with a higher risk of malignancy. So basically, patient with TIF, they can present with amyopathic dermatomyositis. Okay, means that they will have either very no muscle symptoms at all. Okay, just dermatomyositis. But for those that 40 and above, most of the time they can present with muscle symptoms as well. Okay. So prominent cutaneous lesion. Okay. NXP2 for these antibodies, so you can see the frequency there. But the most important thing for this one, for NXP2 antibodies, for the juvenile dermatomyositis, so they can have this increase in calcinosis cutis, means that calcium deposition on the skin. Okay, so this is the main features. For the adult, so this NXP2 antibodies associated with increased risk of malignancy as well, similar to TIF1 gamma. And then for the myopathy, so they can have a little bit, in comparison to myositis in general, which usually will have proximal muscle weakness. For this one, they can have increase in distal muscle weakness and also increase in dysphagia as well. Now, this one quite interesting, anti-MDA5 antibodies. Okay, so anti-MDA5 antibodies so targets the melanoma differentiation associated gene, which is the cytoplasmic protein involved in innate immune response against virus. Okay, so the frequency, so about 10 to 48% in East Asia from adult dermatomyositis cohort. So in US, it's a little bit less. Clinically, this patient will present with amyopathic dermatomyositis, means that they don't have muscle symptoms at all. Okay, but they have this cutaneous manifestation, which can be steroid responsive. But the main thing is that they have this interstitial lungs disease, which can be steroid refractory, means that they will not respond to steroid. Okay, so in terms of the ILD, so like in patient with anti-synthetase syndrome, so this is more acute, rapidly progressive to respiratory failure in 6 months. So these are MDA5 antibodies associated with high mortality rate. Around 45% of the patients will have will die from this lung condition. Okay, but this is very interesting because this, in terms of the interstitial lung disease, progressive interstitial lung disease, this is seen more in this population, in East Asia. Okay, compared to this is not seen in US, not seen in Europe, but only in East Asia. So perhaps this is interesting because we can focus the study on these anti-MDA5 antibodies actually. Maybe looking at the prognosis of the patient and so on. Okay. So all these antibodies, the anti-Me, SAE, TIF, and SP2, MDA5, so they contribute to, it's very useful for dermatomyositis group. Okay. Now the anti-CN1 antibodies, so as mentioned earlier, it's a little bit controversial. Either this is myositis specific or myositis associated antibodies, because now they can also find these antibodies in higher prevalence in Sjogren's syndrome and also SLE. Okay, but for patients with CN1A antibodies, positive patients, so they have increase in esophageal dysmotility. It is important to diagnose for diagnosis of this condition, inclusion body myositis, right? So initially, this IBM is thought to be the T-cell mediated disease, but with the discovery of these antibodies, the anti-CN1A antibodies, so maybe the humoral immunity play a very important role for the development of this condition. So in European group, among patients with the inclusion bodies myositis, they can find the prevalence of the 37% of the patients will have positive for these antibodies. Okay. So this cartoon just to highlight on the location of the autoantibodies, of myositis autoantibodies. So as you can see, most of the myositis associated antibodies, they are located in the nucleus. Okay, so they have different pattern. You can see by antinuclear antibody. So some myositis specific antibodies like Me2, MDA5, NXP2, TIF, SAI also located in the nucleus. So some can be in the endoplasmic reticulum and some in the cytoplasm. Okay. So means that if you do antinuclear antibody test, you can see something actually. Okay. So this is myositis associated antibodies. I think this is quite most that involved with the in the lab. Maybe this is more common to us. Okay, RNP, Rho, PMSCL, Q. Okay, so this is available on the normal ANA profile line immunoassay actually. Okay. So U1 RNP is more for a serological marker for MCTD, mixed connective tissue disease. Okay. So very common also in scleroderma, SLE, PMDM, and also overlap syndrome. So they targets very many groups of the RNP actually. Okay. So for Rho, so this condition is these autoantibodies associated with Sjogren, SLE, scleroderma, and also IIM. So there are two distinct antigens here, 52 and also 60 Rho. But 52 is significantly more prevalent in scleroderma and myositis than 60. So isolated Rho 52 may be found around 37% of patients with myositis, and often this is associated with Jo1. Okay? So actually when it is associated with anti-synthetase antibodies, it can contribute to more severe interstitial lung disease. Okay? So PMSCL, so this again the heterogeneous group of autoantibodies directed against several proteins of the nucleolar PMSCL macromolecular complex. So there are two main autoantigen protein components here, PMSL 75 and 100. So if a person, the pathologist in the lab probably familiar with 75 and 100 PMSCL. Okay. They are associated with SSC. SSC means that systemic sclerosis, polymyositis systemic sclerosis overlap syndrome in approximately around 15% of the patients. So Q initially I thought Q is more specific for myositis, but it is not actually. Okay, so this is again this antibody first reported in Japanese patients suffering from the PM, polymyositis, scleroderma overlap syndrome. So, however, recent studies found this is mostly detected in patients with SLE actually. Okay. So these are the what we call the myositis associated antibodies, the RNP, Rho, PMSCL, and Q. Okay, so in terms of the prevalence, frequency of the autoantibodies in idiopathic inflammatory myositis, so you can see here actually 25% of the patients are seronegative. Okay, so if you look at those that with the autoantibodies, you can see that after the seronegative patients, you have those with the Rho 52. Okay, but as I mentioned, Rho 52 is not myositis specific antibodies, so this is myositis associated antibodies. So perhaps this is maybe belong to the overlap groups. Okay, so about 25%, and then you have the Jo1. Jo1 is around 20%, followed by SRP, PMSCL, and so on. Okay, so basically for the myositis specific autoantibodies, Jo1 will be the most prevalent one compared to other myositis specific autoantibodies. Okay, little bit on the laboratory aspect. Okay, so these are the tests or the method or the procedure or the platform that is available at the moment. So this is the recent review. So you have the line immunoassay, dot immunoassay, PMAT. PMAT is the particle based multi-analyte technology. So line immunoassay again, line immunoassay. So of course this is by different companies. So the first one, this line immunoassay is by the Euroline, Autoimmune. Okay, so these are the autoantigens that we can detect. Okay, so this is by the Trinity Biotech, and then you have this Organtech. Okay, so if you can see here, these four, the 3 line immunoassay and 1 dot immunoassay, they are IVD. Okay, IVD means that in vitro you can use for diagnostic purpose. Okay. So this one, the PAMT by Innova Group. So this is RUO. So this is for research use only. Okay. So you can see quite extensive autoantigens or autoantibodies that can be detected by all these methods. So I think in Malaysia, perhaps most of the laboratories use this Euroline by the Autoimmune. Okay. So this the targeted autoantigens, alright. So can ask Mr. Shing after this, okay? So basically, these are just the cartoon to highlight on the procedures. I'm not going into detail about this. So all these methods, they have their advantages, disadvantages, okay? So this is the immunoprecipitation. So this is considered as gold standard actually, okay, immunoprecipitation. But of course, this is quite difficult to be performed in the diagnostic laboratory. Perhaps for the research purpose, we can do this, especially if we can detect the new auto-antibodies or new antibodies, okay. But again, the new laboratories, new methods actually should be, when we produce new kits, for example, so we need to bench it against the immunoprecipitation technique actually, okay? And then in terms of the approach, because you have a lot of the autoantibodies, now in terms of the clinical approach, so it is better to do the multiplex assay rather than just a single assay. Multiplex assay will increase your sensitivity. Okay, so the sensitivity is around 70-75%. Okay, if you do multiplex. Okay, so if you do a single test, so it depends on the each autoantibody's sensitivity, right? So this is now I come to the role of the autoantibodies, the main part of my topic actually. Okay. But I just want to give the introduction because you need to know on the autoantibodies, what are the antibodies and so on. Okay. So first, the use of the autoantibodies is actually mainly for the diagnosis and classification of the idiopathic inflammatory myositis. So basically, the idiopathic inflammatory myositis can be divided into these 3 groups. Okay, so classically so polymyositis, dermatomyositis, and inclusion body myositis. So in terms of the clinical criteria, so this is the first one, the criteria, Bohen and Peter. So this one is in 1975. So this criteria is mainly solely based on the clinical presentation of the patients. I think also histopathological aspect of it, okay? And then you have more clinical criteria for the myositis. So you have the Targov, Delakas, Tanimoto, okay, between 1990s to 2000s. In between that, this criteria also underwent several modifications, okay. So and then starting from 2004 to 2017, actually 2018, so you have this criteria, ENMC, European Neuromuscular Group, okay, and then you have this American College Rheumatology and EULA classification criteria. The thing is that the ENMC, I think the first criteria that include the myositis specific antibodies, okay. ACR EULA, they also include myositis-specific antibodies, but specifically they only mention anti-Jo1, not other autoantibodies. But for the ENMC 2004 criteria, so they mention about under the laboratory criteria about the myositis autoantibodies. So they give a point there, okay, all right? Not a point, I mean the statement there, okay, so, to include the myositis antibodies. Okay. For the ACR EULA, this one they include only Jo1, but they are long list of the criteria actually. Okay, maybe Dr. Tara more familiar with this criteria. Okay, and then ENMC actually produced another criteria in 2018, but that one just to discuss on the inclusion body myositis. Okay. So this is, So this is the Bohan and Peter classification criteria in 1975. So if you can see, so this is A, B, C, D, E. So there is no myositis antibodies inside this criteria actually. Okay. So you have the clinical symptoms, muscle weakness, and so on. This one is the laboratory test about the elevated serum levels of the skeletal muscle enzyme like CK and so on. And this one is the electromyography findings, muscle biopsy, and then cutaneous changes. So this E criteria must be there for the dermatomyositis. Okay, so polymyositis they have the different classification here: definite, probable, possible. Okay. So this is the history. Okay, the history. So the below one here is the discovery of the autoantibodies for the myositis-specific autoantibodies. So you can see that it was started from 1976 with the discovery of the Me2, and the last one, the recent one, will be 2013 CN1A for the inclusion body myositis. Okay, so in between that you have all those myositis-specific antibodies, right? So this the above one is the classification criteria. So the orange one is the clinico-pathological oriented. Okay, so this one, all the clinical pathological oriented. And then you have this pathological oriented classification, the blue one. Okay, the clinico seropathological oriented. So the blue one, that include ENMC. 2015, 2018, and so on. Okay. So a long way of so many classification criteria for the IAM. So that I think quite confusing. Yeah. So but the extensive description of the myositis antibodies, I think belong to this group lah. The initial one, ENMC, 2003 actually. Okay, 2003. So now this is where we map our autoantibodies just now to the subtypes of the idiopathic inflammatory myositis. So you can see here you have polymyositis. So these are the autoantibodies for the polymyositis, which include the anti-synthetase antibodies. So all those Jo1, PL7, PL12. Okay, and then you have these anti-SRP antibodies. Okay. And then anti-HMG-CR antibodies. And for the dermatomyositis, you have these 5 autoantibodies: Me2, MDA5, SAE, TIF1, and XP2. For inclusion body myositis, you have these anti-CNA1 antibodies. So now, for the polymyositis, so now you can divide the polymyositis into these two conditions. First is the anti-synthetase syndrome. Okay. So whereby you can find these anti-synthetase antibodies. And then you have this immune-mediated necrotizing myopathy, which caused by these anti-SRP antibodies and HMG-CR. So that's the difference. Now, do we have the polymyositis entity anymore? So we still have actually. So you call this as something like classical polymyositis group. Okay? So now, when we look at the the main symptoms. So you plot the autoantibodies with the main symptoms. So the involvement of the muscle, the lung, and skin. So you can see that for the dermatomyositis, typically they will have more on skin part or skin manifestation. But look at this MDA5 antibodies, so they can have this severe lung manifestation, okay, very severe interstitial lung disease associated with higher mortality. For IMNM, so because this mainly involve the muscle, so they will have severe muscle symptoms. Similarly to IBM, they will have severe muscle symptoms. For the anti-synthetase syndrome, so mainly involve the lung, okay, the lung. So, but for the PL7 and PL12, associated with more severe lung disease. So overlap myositis, usually they are not very prominent in terms of the which one is predominant or severe. So you cannot differentiate between muscle, lung, and skin involvement. So overlap myositis basically defined as inflammatory myositis in a patient with classical connective tissue disease features, but they can have this myositis manifestation as well. Okay. So it is more common perhaps in systemic sclerosis, scleroderma patient. So around 5 to 43% of the patients can have this overlapping myositis. A little bit less in SLE and also rheumatoid arthritis. So the role of autoantibodies is also important for the pathogenesis of the condition. So for example, in dermatomyositis, so you can see that there must be a triggering event, for example, viral infection and so on. So that can promote the antigen expression, that can cause the tolerance breakdown and subsequently development of the myositis autoantibodies production. So these autoantibodies will deposit in the endothelial cells, in the muscle and also skin, cause complement system activation. And when you have this complement system activation, there will be recruitment of the inflammatory cells that include the lymphocytes, macrophages, and cause the inflammatory response. So all the symptoms actually related to the inflammatory response that occur in this case. Okay, so patient can present with all these symptoms. So the perivascular atrophy and infiltrate. So this is due to the inflammatory response. So they can from this actually they can block the blood vessel. So it can cause it can cut the blood supply to the muscle. So it can cause the muscle atrophy and muscle weakness. Okay. Similarly, in anti-synthetase syndrome, also the same. So environmental factors causes lung injury. So it exposes the amino acyl tRNA synthase. So result in production of the new antigen, tolerance breakdown, production of the autoantibodies. Again, it will deposit in the sarcolemma of the muscle, as well as in the blood vessel. It trigger the inflammatory response, leads to myofiber necrosis. And here you have the complement-mediated vasculopathy and contribute to all the symptoms actually. So similarly in IMNM also the same. So you have this overexpression or expression of the SRP and HMG-CR antigen on the surface of the myotube. So this can be recognized as the foreign to our immune system, immune cells. So it results in production of the autoantibodies. Actually here you will have elements of the damage and also repair, okay? Damage and repair that occur in the cycle. So you have also the response of the inflammatory cytokines that contribute to the, and also complement activation, contribute to the inflammatory muscles infiltrates, and subsequently results in the myopathy. Okay. So it's something like a cycle here in the IMNM, okay? So this is again in relation to the statin just now. So statin increase expression of the HMG-CR, okay? So when there is increase in this HMG-CR, so there will be break in the immune tolerance because this protein can be presented by the antigen presenting cell. So it results in the production of the autoantibodies and subsequently results in the muscle damage. So the autoantibodies is also important for the prognosis of the patient. Okay, So generally, the prognosis for IIM patient is considered to be good with proper treatment. Okay, but there are certain factors that can worsen the prognosis. First one is older age at diagnosis, cardiac or pulmonary involvement, and presence of certain myositis-specific antibodies. So in this study, actually, when they look at the different groups of the inflammatory myositis, there is no difference in terms of the survival of the patients over the years, right? But from the same study, actually, they are looking. They describe several factors that significantly contribute to the poor prognosis. The first one is the age at diagnosis. Okay, so mostly if the patient's diagnosed over 50 years old and above, so it is associated with a poor prognosis. And then number two is the cardiac involvement. Okay, they are actually wide spectrums of cardiac involvement in myositis. Okay, and then number three is infections. Okay, related to the infections play a very important role as well. Okay, for this study, actually initially they also find that anti-Jo1 also associated with poor prognosis, but when they do multivariate analysis, it is not significant actually. Okay, so this is a study from Malaysia, from a single center experience from Terengganu by Dr. Hashima. Dr. Hashima now I think in North rheumatologist North. I think friend to Dr. Faisal. Okay, so basically this is a retrospective study from January 2010 until December 2019. So the diagnosis of the myositis is based on the ENMC classification criteria. So from that period, they have 15 patients diagnosed with myositis. From this 15, 4 died actually. 4 died. Okay, at the end. So 2 of the cases is due to severe infections. 1 actually due to advanced cancer. So 1 is due to pulmonary hypertension. Okay. So now, what are the autoantibodies associated with poor prognosis in IIM? So these are several of the autoantibodies that related to poor prognosis. So anti-MDA5, as mentioned just now, so it is associated with rapidly progressive interstitial lung disease. Anti-SRP, can have both actually poor and better prognosis. Poor prognosis is actually mainly associated with the rapidly progressive muscle weakness, leads to poor muscle recovery. Better in terms of that, it has less extramuscular complications like ILD. Anti-synthetase antibodies, high risk of interstitial lung disease, but the prognosis is poorer if it is associated with the presence of anti-Ro as well. So among the anti-synthetase antibodies, anti-PL7 is thought to be the risk factor for mortality. Okay. So when you look at the MDA5 antibodies just now, so it can be from this paper, so it can be divided into 3 phenotypes. Okay. So the first phenotypes and the third phenotypes mostly involve women. So in 20% of case, so it occurs in around 20% of the cases. For the type 1, mainly they present with arthralgia and arthritis. This one mainly present with mechanic hands. For type 2 is common in men. Okay, so this is about 50% of cases. So they can have skin vasculopathies, proximal muscle weakness. But the important thing is to look at here. Okay, so the phenotype 3 is associated with lower survival rate. Okay, and higher frequency of rapid progressive interstitial lung disease. Okay, for the phenotype 3. So now, anti-synthetase syndrome and mortality. So among the patients with anti-synthetase syndrome, so these are the important factors that associated with poor prognosis. One is the increasing lymphocyte count per 100/10⁹ per liter, isolated interstitial lung disease, okay, and also presence of anti-Ro52. So, but they also analyze, this is multivariate analysis. A history of cirrhosis also actually play a very important role in terms of the prognosis, but of course it is not that significant, a little bit less than 0.05. But in terms of the hazard ratio, it's quite high actually, about around 9 times higher than normal population. So, and in terms, cancer association. So this is another important role of the autoantibodies. So anti-TIF is thought to be, I think, the well-established one among the myositis-specific antibodies. So anti-TIF is the most established autoantibodies associated with the malignancy. So you can see from all these studies, so this is collection of different studies, it is quite significant that the prevalence of the anti-TIF in cancer dermatomyositis, in non-cancer dermatomyositis, and also prevalence of malignancy in anti-TIF positive dermatomyositis and negative dermatomyositis. So in both situations, the correlation is very much significant, you know, except for this one study from Japan. But you have another data, but this one is only a small number of patients, okay, 55. But other studies from Japan that involving more patients, so you can see a significant relationship between TIF and also malignancy. So now, looking at this paper, so this is the paper that looked into 115 cases, a study from China. So they have the 600 something dermatomyositis. So they divided into two groups. One is under 40. So patient under 40, you can see that there is about 7.4% had malignancy, okay? And then no difference between female and male. For group 2, 40 and above, so they have about 34.4% of the patient had malignancy, and male is more common than female in this group. So now, what are the cancer types associated with this dermatomyositis? So the cancer type include in China. This study is in China. So the first one is nasopharyngeal carcinoma. So it's about 51.3%, followed by lung cancer about 17.4%, liver cancer in 9 patients, and you have a lot more cancer actually, the female reproductive cancer and so on. And the diagnosis of cancer, when does it occur? So majority of the patients, about 79 over 115 patients with malignancy, 79 of them was detected within 3 years of dermatomyositis diagnosis. Okay, but in this study, of course, they don't look into the association with the autoantibodies. Okay, just in dermatomyositis patients in general. So in terms of the mortality, majority of deaths among this study, most of the patients, majority of them died because of the malignancy, about 43 cases, and followed by the lung infection. So this is, I think, few couple of last slides, just to share with you in terms of the difference between adult and also juvenile idiopathic myositis, okay, inflammatory myositis. So just look at the certain autoantibodies like TIF, which is frequently occur in 35%, around 17 to 35%. But just to highlight on the clinical features here, so they can have more severe cutaneous disease, okay. But actually for TIF, for the juvenile type, it is no cancer association, okay. It is not associated with the cancer, okay. But for the adults, it is associated with a malignancy. And SP2, again for this one, the most important features is calcinosis. Of course, in adults also they have this calcinosis. Again, some studies show that an SP2 also associated with malignancy, but this one is not not definitive yet. Okay, some studies suggest there is, some studies suggest no. Okay, and then MDA5 for the children, the difference that they don't develop rapidly progressive lung disease compared to adult. Okay, so for the Me2, they can have this. For the children, they can have this dysphagia. Okay. Compared to adult, mostly they have skin and muscle weakness only. And Me2 is actually associated with another autoantibodies associated with favorable prognosis in adult. Again, or these antibodies like SAI, so not so much different. Antisynthetase syndrome, of course, for both they have lung disease actually. SRP, so higher risk of dysphagia in children compared to adult. HMGCR, of course, very rare in children. If you think about statin, so of course we don't normally prescribe children with statin, right? So this is very rare. But if it happens, so it is associated with severe proximal muscle weakness, similar to adult group actually. So in conclusion, so myositis antibodies can be classified into myositis specific and myositis associated antibodies. And the role of myositis antibodies is actually very, very important for diagnosis. So as highlighted by the classification criteria just now. And then to classify the myositis into subtypes, and informing the prognosis and maybe cancer association. I think that's all for today. Thank you.
Thank you, Dr. Asrul, for the informative presentation. For our online viewers on YouTube Live, we share a link for you to post questions for our speakers and will later be answered by the speakers through email. Are there any questions from the floor? Okay.
Hello, Assalamualaikum. Thank you, Professor, for a very insightful presentation. As you mentioned just now, based on the your slides mentioned about quantitative JO1 results that can be tested other than using immunoblot. There's also another method which is PMA, which is report in quantitative. Beyond the use of these autoantibodies, other than classification and diagnosis, is there any role of monitoring purposes as in terms of myositis?
Yeah, I expect that question. That's why I don't put in the slide. So basically, for the monitoring, so it's still under what we call this under investigation. We don't have a concrete evidence to use the autoantibodies as monitoring tool at the moment. Okay, but maybe after we have all those studies completed and so on, maybe we can have that later on. Monitoring means that we need to do quantitative rather than qualitative. Test. Okay, so most of the time when we use the immunoblot or line immunoassay, we report qualitative rather than quantitative. But of course, they say that it can be used as semi-quantitative, but usually we don't do that for the sake of the reporting the results. Actually, yeah, I think if you want to do monitoring, there are maybe some markers that are very important for monitoring. For example, MDA5 or JO1, for example, so that can be used as monitoring. But as far as I know, at the moment there is no approved test to be used for the monitoring. I can see that perhaps the chemiluminescent assay can be one of the good method to go with it for the monitoring and so on. Even to do multiplex with chemiluminescent assay, it's maybe easier to do. I don't know. But again, if you want to introduce anything new, you need to do study with using the immunoprecipitation as your gold standard lah. That is what has been suggested. But I think we can look into other ways lah. Okay. But the immunoprecipitation is not that easy. I think in some of the steps they use the radioisotope as well, so it's quite difficult. Yeah.
Okay, is there any question? Okay, thank you, Dr. Asrul.
Thank you.
Okay, I would like to request Dr. Asrul to remain on the stage and invite Dr. Masita to present a certificate of appreciation to our speaker. Okay, thank you, Dr. Masita. Distinguished guests, ladies and gentlemen, for the next session, you are welcome to some refreshment. Refreshment will be served at the Cafeteria Sihat, level 5, located at this level, the ends of this building. Kind reminder that we will take a 30-minute break, so please come back to this auditorium by 10:30 to begin our next session. But before we proceed for the tea break, let's have a photo session with our distinguished speaker. So please remain seated for a while. Thank you. Okay, please come to the center. Okay, thank you. You all boleh gerak ke sini sikit, yang belakang. Yeah. So, I hope everyone had a nice break. We shall proceed to the next session now. Please, so the music. Okay. Alright, thank you. Okay, ladies and gentlemen, we are going to continue our seminar with Dr. Ahnis Abdul Hamid from Hospital Selayang on the topic laboratory experience on myositis. Dr. Ahnis Abdul Hamid is a pathologist from Hospital Selayang. She holds a Master of Pathology in Clinical Microbiology from University Putra Malaysia and currently serves as the Secretary of the Malaysian Society of Infectious Diseases and Chemotherapy, MSIDC. Her professional interests include transplant virology, infectious diseases, antimicrobial resistance. Dr. Ahnis is actively involved in national research project under the National Pathology Research Committee, focusing on improving microbiology diagnostic and laboratory practices across Malaysian hospitals. Without further ado, Dr. Ahnis, the floor is yours. Thank you.
Okay. Assalamualaikum and good morning. So thank you for the kind introduction. I'm Dr. Ahnis, a clinical microbiologist from Hospital Selayang. I stand here as a medical doctor and also as a laboratory representative, sharing what we quietly witness from behind the bench. Myositis is a rare disease, yet in our lab, its presence has been steadily rising. And today, I'd like to show you what that means. So thank you to the organizing committee, Dr. Masita, Dr. Siti Fatima, and ARC for allowing the laboratory perspective to be part of today's discussion. There will be overlap between my talk, Prof. Asrul's talk, maybe Dr. Tara's talk, Mr. Lee, and Dr. Tu also. But like Horace, a Roman poet, said, repetition is mother of learning. And shout out to my mom and dad since we are live on YouTube. Hi. So, okay. So myositis, like Prof. Asrul has mentioned, it's idiopathic inflammatory myopathies, and they're not a single condition, but a diverse group of autoimmune diseases. And the key here is autoimmune, meaning the body's own immune system is attacking its own cells. And the hallmark feature which brings a patient to the doctor are chronic muscle inflammation that leads to muscle weakness. And this is a core clinical sign. However, it's crucial to understand that IIM are complex systemic diseases. This means they go far beyond just affecting the muscles. The inflammation can impact the entire body. And because of this systemic feature, we frequently see multi-organ involvement. Manifestations such as rash, arthritis like pains in joints, cardiopulmonary involvement, and gastrointestinal involvement. And furthermore, patients also experience constitutional symptoms like fever, fatigue, and unexplained weight loss, and which is driven by the body's inflammation. So Prof. Asrul has given us a very good overview of the criteria that's used to diagnose idiopathic inflammatory myositis. So I'll just refresh your memory. So the key, where's this? Okay, so the key subgroups classified by the experts are polymyositis, characterized by muscle inflammation, dermatomyositis, muscle inflammation accompanied by characteristic skin rashes, anti-synthetase syndrome, defined by specific anti-tRNA synthetase antibodies, immune-mediated necrotizing myopathy, amyopathic dermatomyositis, inclusion body myositis, and overlap myositis. So the IIM diagnosis is suspected on clinical grounds, confirmed by muscle biopsy, MRI, or electromyography. And these are, especially the muscle biopsies, are pretty invasive. So non-invasive methods, we have the general blood laboratory testings like muscle enzymes and inflammatory markers. Then we come to the autoantibodies, where we have the myositis-specific autoantibodies and myositis-associated autoantibodies, which Prof. Asrul has elaborated earlier. So again, a refresher, myositis-specific autoantibodies, they are noticed in IIM patients. And these are the specific autoantibodies that identify the subtypes of IIM and suggest the development of distinct clinical features and outcomes, whereas autoantibodies that are also seen in other autoimmune connective tissue diseases are coined as myositis-associated antibodies. So, So when we talk about myositis diagnostics, it's important to recognize that the methods we use today have evolved from research-based tools to clinically practical platforms. First, immunoprecipitation, which Prof. Asrul has mentioned earlier, remains the gold standard because it captures native proteins, complexes, and even RNA-associated antigens. It is the most accurate, but it's highly technical and is confined to research laboratories. Secondly, ELISA brought higher sensitivity and quantification. It allows targeted detection of specific antibodies and can be used to monitor disease progression over time. However, ELISA, to my knowledge and to this presentation, it works as one antigen at a time, so which limits its efficiency in complex diseases. So next we have the line immunoassay and the dot blot, which has changed the game by allowing multiple myositis antibodies to be tested simultaneously. These multiplex platforms are widely used in clinical laboratories such as ours today. More recently, particle-based multi-analyte technology has emerged as a modern digital method, providing good agreement with immunoprecipitation and offers automated quantitative results. It's promising, but it's still not universally available. Finally, immunoprecipitation combined with mass spectrometry represents the future of discovery. It's been instrumental in identifying new antibodies. So while immunoprecipitation gave us discovery, it is multiplex platforms like LIA that allows us to bring precision serology into everyday clinical practice. So this graphic illustrates the historical timeline of myositis antibody discovery, showing how each antibody emerged over time and how each has contributed to defining distinct clinical types. And the colors that you see are representing that which clinical association they have. Like the blue is with lung and CTD. Where's the pointer? This one. Which is the pointer? Oh, here. Oh. Okay. So here. So you get the lung and CTD. These are the skin diseases, okay, muscle diseases, and these are associated with malignancy. So earlier antibodies were broad and non-specific. Modern antibodies define clinical subtypes and help predict interstitial lung disease, cancer, and necrotizing myopathy. So let's get to know our antibodies. This is a repetition from Prof. Asrul's slide. Okay. So we have the anti-aminosyl tRNA synthetases, ARS antibodies. They are the most common myositis-specific antibody groups found in 25 to 35% of IM patients. They attack the ARS enzymes, which are essential for building new proteins. The key types of the anti-ARS antibodies have been identified as Jo1, PL7, PL12, EJ, OJ, KS, ZO, and HA. Anti-Jo1 is by far the most frequently detected in 15 to 25% of patients with polymyositis and dermatomyositis, and the others are much rarer. So the presence of these antibodies are characteristics of anti-synthetase syndrome. So anti-Jo1, it was the first myositis-specific antibody to be described in 1976 and then characterized in 1980. It targets histidyl tRNA synthetase, which is a crucial enzyme for protein synthesis. And it was not detected in other patients that had SLE, RA, or sclerosing scleroderma at that time. And this marker is also present in our ENA panel. The prevalence of this is about 15 to 30% in polymyositis patients, and 60 to 70% of polymyositis patients with anti-Jo1 also present with interstitial lung disease. Okay, so then anti-PL7 and anti-PL12, described in 1984 and 1986 respectively, targets the threonine and alanine tRNA synthetase. It's rare, it's about less than 5% of IM patients, and some have been reported to have ILD association. The next is anti-EJ and OJ. First described, not orange juice, but just OJ. Okay, first described in 1990, targets the glycerol and isoleucyl tRNA synthetase. It's rare, it's less than 5% of patients with polymyositis and dermatomyositis. And their reports of anti-OJ are more closely associated with ILD than with myositis. So then we have anti-KS. It was described in 1999, targets the asparaginase RNA synthetase. It's rare, it's in less than 1% of patients with myositis, and it's associated with interstitial lung disease, which was the sole manifestation in 50% of the cases. And they may have other manifestations of antisynthetase syndrome, which is like arthritis, Raynaud's phenomenon, mechanic's hand, and muscle, but muscle involvement is slightly rare. Then we have anti-ZO and anti-HA. So they target the phenylalanine tRNA synthetase and tyrosyl tRNA synthetase. Anti-ZO features were first described in 2007. It has a very strong link to anti-synthetase syndrome. In a small cohort of 9 patients, 7 out of 9 patients had muscle involvement and interstitial lung disease. 3 of them had cutaneous signs, and there was a female preponderance, and the onset was about 50 years of age. 66% were associated with anti-Ro52 positivity, and this showed a severe interstitial lung disease risk. And it was also reported among the Asian IIM patients. Anti-HA is rare, likely under-recognized. In interstitial lung disease cohort, 2% showed positivity to this enzyme. And it's seen in some connective tissue disease patients, idiopathic pulmonary fibrosis, hypersensitive pneumonitis, and non-classifiable ILD. So this is a summary of the antigenic targets, their estimated prevalence, and the clinical phenotypes of the individual ARS antibodies. So I'll give you a few seconds to just have a look at the slide. It's a repetitive of what Prof. Asrul and had mentioned earlier. Okay, so now we go to melanoma differentiation associated gene 5, MDA5. It's directed against the dsRNA innate immune receptor. Its primary association is strongly linked with clinically amyopathic dermatomyositis and a high risk of rapidly progressive interstitial lung disease. The hallmark features are deep punched-out skin ulcers and tender palmar papules. There's a high prevalence in Southeast Asia, about 10 to 48% of IIM patients have this antibody, and it's slightly lower, and it's much lower in Europe. 50% of patients with MDA5 positive have a strong association with rapidly progressive ILD versus those who are anti-MDA negative. So positive result requires immediate ILD assessment and aggressive immunosuppression. Oh, sorry. Okay, I'll give you a few seconds to read that. Okay. Next is the immune-mediated necrotizing myopathy, the NTSRP, signal recognition particle. It was discovered in 1986. It's a cytoplasmic complex RNA and polypeptide chains that is involved in translocation of secretory, lysosomal, and membrane proteins across the endoplasmic reticulum. Remember Prof. Asrul showed you a nice picture just now of where those little different antibodies work in the cytoplasm, in the nucleus, in the endoplasmic reticulum. So this is where this one is, affects the endoplasmic reticulum. The pathology shows severe necrotizing myopathy with minimal inflammation. Clinical features of the patients, they have marked proximal muscle weakness with high CK. 60% of them have muscle atrophy and weakness, and 41% may have dysphagia. Extramuscular disease presentation is rare. Interstitial lung disease is less than 22%, and there's minimal arthritis or Raynaud's phenomenon. They're often refractory to steroids, and 77% need additional immunotherapy, and they have poor long-term muscle recovery and risk of permanent disability. And the next antibody associated with immune-mediated necrotizing myopathy is anti-HMGCR, the 3-hydroxyl-3-methylglutaryl-CoA reductase. So this was discovered in 2010. It's a novel antibody directed against certain proteins in patients with IIM who had been exposed to statins. While the link to statin exposure is there, but they can occur in patients without statins. Dr. Tara, you can correct me if I'm wrong about this. Okay, so HMGCR is upregulated in the muscles during statin use. And clinical features could be from mild self-resolving muscle ache to significant myopathy with raised CK and rhabdomyolysis, severe muscle weakness, and some will have dysphagia. Okay, extramuscular features are uncommon. So the management is to stop statins and to initiate immunosuppressions. The outcome is generally better than SRP, the less aggressive progression, and better neuromuscular recovery. Okay, the next one we have are the cancer-associated dermatomyositis antibodies. TIF1 gamma is known as transcription intermediary factor 1 gamma. It was identified in 2006 and confirmed in 2012. The prevalence is about 13 to 21% of adult dermatomyositis. Strongest link to malignancy, especially in the elder population. Clinical features include extensive cutaneous dermatomyositis features. Interstitial lung disease is uncommon, and there's variable esophageal involvement. NXP2 was identified in 2013 in adult dermatomyositis patients. There's a 3 times increased risk of cancer. Clinical features include distal muscle weakness, subcutaneous edema, myalgia, dysphagia, calcinosis, and interstitial lung disease is less common among these. Next, we have the anti-SAE1 dermatomyositis, identified in 2007. Targets the small ubiquitin-like modifier activating enzymes and seen exclusively in dermatomyositis. The prevalence in the UK is about 8% of dermatomyositis patients and 3% in China. The clinical features, they have the classic dermatomyositis rash and dysphagia. But interstitial lung disease presentation is variable. It's higher actually in the Chinese study, where it's about 70%, whereas UK was about 17%. So this suggests that regional variation and environmental influence are factors here. And the next we have is the anti-MI2 antibodies in dermatomyositis. So the MI2 proteins are part of the chromatin remodeling complex. They regulate gene expression via the ATP remodeling and histone deacetylation. And it was the first dermatomyositis-specific antibody discovered in 1985. The prevalence was found in about 5 to 10% of dermatomyositis patients. The clinical features are prominent classical dermatomyositis signs such as the Groton's papule, heliotrope rash, V sign, and Scholl sign. Dysphagia is common among these patients, and there's a low incidence of interstitial lung disease and malignancy. They have a better treatment response, and they have a more favorable outcome compared to all other dermatomyositis antibody subtypes. So this is a list of the diagnostic relevance of autoantibodies in myositis. We've listed them all. You can see that there are some associated with overlap syndromes, and some are quite specific to ASS or ILD. Okay. So now we come to my part of the talk. If I were to just talk about my laboratory experience, I'll finish it in 10 minutes. So that's why I had to, give a little bit more of introduction and, talk about the antibodies. So here we are, myositis testing experience. We started myositis testing in August 2024, and the testing was open to the rheumatologists, neurologists, and also to the respiratory physicians. And this is the kit that we use. We use the autoimmune inflammatory myopathies, 16 antigen. That's the kit. Okay, so this is the strip with the antigens on them, and that's the analyzer that we have. So test characteristics, it's a qualitative blot method, so there's no measurement range. And the high analytical specificity of the test is guaranteed by the quality of antigen substrates used. And it specifically detects the IgG class of the 16 antigens that are listed there. And no cross-reaction with other autoantibodies have been found according to the manufacturer. The prevalence and specificity, there was a study in Sweden that about 153 myositis patients and 77 autoimmune controls, and the antibodies tested were the 16 antigens, and the prevalence of each antibody about 3 to 12%, and specificity was 97 to 100. So, and the total antibody detection was about 26% of myositis patients. This study was replicated in Italy, and it found similar findings, slightly higher because I guess the cohort was bigger. It showed that the prevalence of each antibody was 4 to 21%, the specificity was 95 to 100, and there was a total panel detection of 37% of myositis patients. And a more recent one in 2019 showed a bigger cohort of 805 myositis patients using the 16 antigen panel, and the specificity was 97 to 100%. Individually rare antibodies were detected with this panel testing, and they detected rare MSAs like MDA5, OJ, and TIF1 gamma. So the key takeaway is that using a panel of multiple myositis antibodies improves diagnostic yield. So now we come to our lab workflow. So this is the protocol that we use and follow. Okay, there's a lot of steps involved. Okay, and so I have a video. I hope it plays. So let's see. Okay, so this takes place in the entire day. Okay?
I'm just calling to say I
As you know, Selayang, our system is still down, so we have to manually tick the results for everybody. Okay, so globally, serologic profiles help define myositis. But what about our Malaysian patients? So this is where our data comes in. So since we started in August 2024, so from August 2024 to December 2024, we had about 108 samples. 21 samples were internal samples and external were 87. So this was a distribution of our external samples. And out of the 108 samples that we received, 57 or 52% demonstrated seropositivity for one or more of the myositis-specific or associated autoantibodies. And about 25% exhibited single autoantibody, whereas 26% showed multiple antibody reactivity. And the remaining 47% was seronegative. So here we have the single positive antibody. As you can see, row 52 was the most frequent standalone antibody isolated. Okay, we have OJ, MDA5, JO1, T1F1 gamma, which are well-known strong phenotype drivers. But we also noticed for internal samples, there was no ENA done prior to sending for myositis panel. And for external samples, we could not capture that information. For the multiple antibody positives, we can see that Rho is also associated with a lot of the antibodies that is co-positive with those. And we also saw some NXP2 and TIF1 gamma, which raises the question, are these red flags for any possible malignancy? So now we move to January 2025 to September 2025. So in the 9 months, we have received 360 samples, which is a 233% increase in samples that we have received. 40 samples were internal, 320 were external. So this is the sample distribution. Okay. So again, the findings are similar to 2024. It's about 50% overall seropositive rate. Okay. And again, the single antibody type, row 52, was still the most common. Then we saw some cases of TIF1 gamma, KU, MDA5, JO1, NXP2, and Me2 betas. And in the multi-antibody group, Rho52 was again the most frequent co-antibody appearing in majority of the combinations alongside SRP, PL7, JO, KU, TIF1 gamma, and MDA5. And it raises the question, could these patterns suggest that Rho52 may serve more as an immunological marker? Prof. Asro did show some papers that Rho52 was more frequently, isolated. The dual combinations was seen with Rho52 and SRP, and Rho52 and PL7 that were quite dominant in our cohort. Triple, quadruple antibody profiles were rare, but are they potentially significant? Okay. Again, while these serologic profiles in the single and the multiple antibody profiles, they are notable, we don't have clinical data to correlate disease severity and outcomes. But interestingly, our findings are not entirely isolated. So an influential cohort study by Corellas, cited over 50 times in PubMed, identified that Rho52 was the most frequent autoantibody, even exceeding classic MSAs like JO1 and MI2. This supports the idea that Rho52 may play a more central role in myositis spectrum than previously assumed. But this study was done in Brazil and over a decade ago. And our emerging Malaysian data may reflect similar trends, suggesting it might be timely for us, Dr. Tara, Prof. Asro, Siti Fatimah, Dr. myself, to join forces and maybe re-examine the significance of Rho52 in our clinical context. So, how much does it cost? Okay, so our current panel is about 256 ringgit per test. And in the first 9 months, we have already reached 92,000 ringgit. Okay, and there have been questions, why does our panel have HMGCR? So we do aspire to start to provide HMGCR. So that will be a 20-panel autoimmune test, and that would be about 500 ringgit per test. Okay, so this plays a key consideration as we plan how to continue providing this essential service. So what's the roadmap for our myositis diagnostics? So as I mentioned, we are targeting a comprehensive 20-antigen panel to enhance diagnostic specificity and cover a wider spectrum of myositis. But you had a glimpse of how much that would cost. We will actively monitor the market for technologies that offer a better balance of cost and performance. And the long-term vision is, of course, a walkaway system that frees up skilled staff for more complex tasks. We aim to strengthen collaboration with clinicians to refine testing algorithms, improve antibody interpretation, and develop a smarter, more intuitive strategy for diagnosing myositis. In parallel, we hope that this anonymized laboratory data can be used to identify local disease patterns, ultimately building a clearer clinical landscape that supports better decision-making and personalized care. So in conclusion, as you can see from our first point, the demand for myositis testing has risen sharply. Between August 2024 and December, we processed 108 samples, and in just 9 months of 2025, the number has surged 233% more. That's 85% more monthly. Okay, so this isn't a number. This clearly reflects the growing clinical awareness and increasing demand for specialized myositis testing across the country. And it confirms that we are fulfilling a critical need. As the sole referral center for this testing, the external samples constitute the vast majority of our workload, highlighting a critical need for our specialized services. Anti-Rho52 was the most prevalent antibody in our cohort, not only as a single monospecific finding, but also as a frequent co-antibody in multi-reactive profiles. This raises an important question. Should we do ENA before proceeding with myositis panels? From a cost-effective and diagnostic workflow process, incorporating ENA as an initial screen may help streamline testing for suspected IM cases in our local setting. This is probably where we can join hands with Dr. Tara on how we can optimize the sequence of serological testing. And looking ahead, our strategy is to expand diagnostic capability through broader panels and the adoption of carefully selected advanced technologies. Because as testing demands continue, we recognize that our workforce cannot expand at the same pace, making laboratory automation and workflow optimization essential to sustaining quality. Strengthening collaboration with clinicians remains central, ensuring that every result we produce delivers maximum clinical value. And with these priorities in focus, we are prepared to build on this year's progress while advancing towards a more efficient and precise diagnostic service. So meet my team, it's a bunch of us, okay? Okay, before I conclude, I would like to dedicate this entire presentation to the loving memory of Dr. Suhaila Baharudin, a senior, a mentor to many, a cherished friend and a colleague in our microbiology fraternity. For us in microbiology, the commitment to understanding and diagnosing myositis is more than scientific. It is profoundly personal. On October 30th, 2024, we faced a heartbreaking loss when Dr. Suhaila succumbed to MDA5 positive myositis with rapidly progressive ILD. Though her passing has left an irreplaceable void, her spirit continues to guide our purpose. In her honor, we remain steadfast, striving for excellence, serving with integrity, and pushing forward despite limited resources. Her legacy lives on in every diagnosis we refine, every life we hope to protect, and in every act of service we offer to patients and clinicians alike. Thank you. Oh, any questions? Yeah.
Okay. Thank you, Dr. Anis, for an interesting presentation. Are there any questions from the floor? And for our online viewers on YouTube, you can write your question and post in the link provided, and our speaker will be answered through email. Thank you. Any question?
Oh, you all can ask me later.
Okay. Okay, Doctor. Yeah, please remain on the stage and I invite Dr. Masita to give a certificate for his presentation.
Oh, tak tanya soalan ke?
Oh, okay.
We can chit-chat there only.
Okay, we have a question.
Okay, thank you, Dr. Anis, for very informative, interesting with the video. I think all of us really enjoy with the video lah, especially. So regarding the role of, I want to comment lah. Actually, it's not the question.
Okay.
I want to comment about the INA role of myositis testing. For me, it depends on the INA, what's inside the INA actually. If antigen inside the extradable nuclear antigen not covered all the antibodies, not antigens inside the INA, so I don't think it can be used as screening. But if you use an anti-nuclear antibody immunofluorescent technique, that one can be as a screening. But I understand nowadays in the hospital they do different. They do the ANA screening using the either clear or whatever. Not necessarily use that as the screening nowadays. So in other words, we still need the the myositis panel actually to diagnose all the condition that we mentioned earlier. In other words, I hope the vendor here can actually help the government lah. Because as you can see, the cost of Autoimmune test is quite expensive for us. Maybe because of the currency, Euro versus Malaysian ringgit. So Shing, I hope you can help the Selayang Hospital, Chemo Farm, to ensure that, because I think after this there will be more requests of this myositis. Before this, for information, during our time in IMR for INA, Joan actually not really positive. It's very seldom, right? Like maybe 10% positive, not even 50%. But now we can see, using the myositis panel, 50% of the sample received in Selayang is actually positive. So in other words, very important test lah. Okay, thank you very much Selayang for covering the myositis panel. I hope you can achieve more lah. Thank you very much.
Yes, maybe one question. From your experience, because I think I have this problem as well. Row 52. So row 52, You see, we have this ROT52 in NR panel, in liver panel, in myositis panel. Not myositis panel lah, but these two lah. Usually they are quite frequent. We can find these autoantibodies positive in our sample. Do you have that kind of experience as well?
I will have to get back on it because I did not analyze the others.
but sometimes we don't know, is it really clinically significant or not?
Yeah. I guess that is something that my team and I will look into. We will try and reanalyze our data and see what's our positivity rate for Rho in our other testing.
Because for the liver, as for example, so when it is isolated Rho52 positive, sometimes it's very difficult to explain, you know.
Maybe Dr. Siti want to say something?
I just think it is just oversensitive. I don't know.
From our experience, so we can say that we quite a lot are RO52 isolated positive, but I'm not sure is it like Dr. Asrul said, is it due to, is it a significant one or not? Maybe
this is where I think it's important that we come together.
True.
We need to look at the clinical aspect of patients, what they present with, the
because,
comorbidities and everything, and then look at it as a big picture. Then we'll be able to streamline how does this RO52 fit in our clinical context here.
Because currently we are just received the sample.
Yes,
because,
exactly.
Right?
Yes.
Maybe
so
after
now
this.
we have Dr. Tara here with us, so we can work through something.
Okay, Dr. Tara.
The pressure's on you.
Any other question? No, okay, thank you for the interesting sharing session. All right. Yeah. I would like to invite Dr. Masters on there. Okay, thank you, Dr. Masita. Ladies and gentlemen, moving on to the next session, this talk is entitled Updates and Clinical Challenges of Myositis, which will be delivered by Dr. Tara Mahadevan from Hospital Kuala Lumpur. Dr. Tara Mahadevan is a specialist from Hospital Kuala Lumpur, and research and interest focus on dermatomyositis, lupus, and inflammatory myopathies. Please join me in welcoming Dr. Tara Mahadevan to deliver her presentation. Thank you.
Okay, hi, good morning, everyone. First, I would like to take the opportunity to thank Dr. Fatima for inviting me to give a talk today. So I'm Dr. Tara Mahadevan. I'm a rheumatologist currently now based in HKL. And myositis is actually something that I'm actually quite fond of, and I have actually grew interest in it. And during my third year final training, I actually spent 10 months in Manchester, Salford Royal Hospital, which is the myositis center, where I worked with Prof. Chenoy. So there actually I realized there's a lot of things that we actually need to learn about myositis, and that actually just made my interest grow more, you see. So I'm very, very happy that I was actually invited to give a talk today, because I do not know who to approach and say, I'd like to talk to you about myositis and what I've done, what we can improve on, you see. So as Prof. Azrul has mentioned, and as Dr. Anis has mentioned, myositis is a heterogeneous condition. It's a condition that involves multi-system. And as you can just see here, this is the lung involvement, this is your MRI of your thigh, and even here they come with arthritis. Some patients just come only arthritis, some just come with only lung involvement, you see. And here you might not appreciate so well, but this is actually a bit of a mechanic's hand, all right? So my overview today, I will actually be just one slide on the pathogenesis about myositis. I will also highlight on the therapeutic innovations for it. This is also another important things that we have to discuss about our clinical challenges and our unmet needs in myositis, especially in Malaysia. And we'll also explore the future directions in myositis care, where I'll just put a few slides on what is being done in UK currently. And of course, I would like to end with a few 2-3 cases regarding myositis, so that you also will be alert about it. Okay, so as I mentioned, myositis is a heterogeneous condition. It's a multi-system involvement, but the predominant symptoms is skeletal muscle involvement, where they come with proximal muscle weakness. Now, having said that, we have patients where they do not have muscle involvements. They just come with skin rashes, and these are patients where we call them clinical CADM, so clinical amyotrophic dermatomyositis, where it's just cutaneous manifestation but no muscle involvement, and their CKs are actually normal. Okay, and I was mentioning this to Dr. Anis. I actually find it hard to believe that we don't have many myositis cases in Malaysia. I do personally feel it's actually under-recognized. I think the availability of myositis antibody also probably makes this a bit difficult to diagnose. But I think also among the healthcare doctors, we need to be more aware about myositis. So it's not just here, it's also in many countries. Because there's not many cases, they're not able to do a large cohort studies, and because of that, we have not yet come up with a diagnostic criteria. These are all just classification criteria, you see, to guide us on myositis and to diagnose someone with myositis. I'm very happy that there's actually now, I think 20 years ago, we did not have myositis-specific antibodies and associated antibodies. So that time, we used to diagnose myositis with purely muscle biopsy. And in UK now, and many other countries also, they have actually now gone ahead and said, you do not need muscle biopsy to diagnose someone with myositis. You can just have a myositis antibody panel, and that alone is enough. Why? Because most of your MSA panels are mutually exclusive. Means it always has one antibody that's positive. But now when I come to Malaysia, I do not know why, so I'm a bit reluctant to say that it's mutually exclusive. As you can see, Dr. Anis has nicely put up her slides where there are patients with 3 antibodies positive. And when your antibodies are positive, that's when you have to decide, oh, what clinical manifestation does this happen, which I'll show you in the next following slide. So for me, it depends on the case scenario, whether MSA alone is enough or do I need to go ahead with a muscle biopsy. So pathogenesis, as you all know, myositis, also another name we always call it is idiopathic inflammatory myopathies, but I'll just call it as myositis. It's an autoimmune condition, and just like all autoimmune condition, you must understand that our immune system actually plays a very important role as a host defense against all the harmful antigens, and it also balances your tolerance and the immunity of your antigens. So when someone develops an autoimmune disease, it's because their autoimmune system is not able to discriminate between the self-antigen and non-self antigen. Okay, so in our immune system, you have your innate and adaptive immunity. Of course, external factors, there is genetic factors that play a role. Environmentals, they still say, of course, smoking, UV light radiation, and that's the same for other autoimmune conditions as well. So your first line defense mechanism is always your innate immunity, where your body will recognize any virus or anything, and your PRP, where it's like your mast cell, neutrophil complements, that's where they undergo phagocytosis, endocytosis, and then they release your inflammatory cytokines like your IL-1 and your TNF as well. And then it goes to a bit more specialized adaptive immune system, where your specialized receptors, right, like your toll receptors, all play a very important role in there. And that's where your CD8, your CD4 differentiation happens, and your B cells actually start producing antibody. And if you, over here is more or less the non-immune mechanism, where it's been proposed about this, but I can't confirm it. There's many articles that propose possible pathologies of myositis. So here they also say about stress to your endoplasmic reticulum due to some build-up proteins, and that will increase your MHC class 1. Muscle hypoxia is also another thing that will also predispose to myositis. Autophagy is also another condition. So all this at the end of the day will lead into inflammatory myositis depending on the organ involvement. So this is actually a slide that for us rheumatologists it's very important, because actually it helps guide you on how to diagnose a patient. So now 15 years ago, we will say, yes, this is polymyositis, but now we try to move away and say this is polymyositis. We say this is TIF1 gamma dermatomyositis, because you already have an antibody. And once you have a TIF, so here, so I'll just go here. So say if I suspect someone has lung involvement, when you do a myositis antibody panel, and I get this kind of antibodies, immediately if I say, oh, if I have a PL7 there, then I say, oh, this is definitely anti-synthetase, you're going to have lung involvement. So this guides me straight away. I'm not going to waste time and say, chest x-ray looks a bit, okay, maybe just very mild reticular changes at the bottom. I was already send a patient for HRCT, because that's where you're going to pick up all the lung changes, and that's where you want to address and treat the patient as fast as possible before they deteriorate. Then you come with the MDA5, which also has lung involvement. And besides just lung involvement, they also have skin involvements, MDA5. So when you know someone has MDA5, you already know, okay, skin, because they are quite known to have rapidly progressive ILD. So you immediately do a HRCT, and then that will also guide you in your treatment, because you know majority of MDA5 are rapidly progressive ILD, so you may want to give a stronger immunosuppressant. So this actually guides us in our management. And so in skin involvement, as Prof. Azrul also has mentioned, there's SAE, Me2, and then your NXP2, yes, it's associated with calcinosis as well. But I've not seen much NXP2 actually, but in UK I've seen one NXP2 with calcinosis. And then you come to your overlap myositis, where they will have PMSAL, your ROS, your SNRP, and also your Q. So sometimes we see patients where, like what Dr. Anis has mentioned, there's only RO positive. So for us rheumatologists, when you say RO positive, we think of Sjogren's. Do you have dry eyes, dry mouth symptoms? Then we tend to think, okay, Sjogren's, not so, we don't really have to worry so much unless they don't have any Zika symptoms, dry symptoms, you see. But you'll be surprised, when I was in UK, I actually saw a patient where they only had RO positive, came in with muscle weakness, sent her for a muscle biopsy, and it's actually a myositis. So they labeled her as RO myositis. So I agree with what Dr. Ani said, that I think RO is something that we need to look into. Many of the articles says that when you see someone with an ILD condition like anti-synthetase MD, and you see a RO 52 positive, then that means their ILD is more severe actually. So then comes your inclusion body myositis, which is your 5NA1 antibody. And then you have your necrotizing myositis, where you have your HMG-CR and your SRP. So for us, that's why if you look at this slide, if it's nicely divided to you and told you, guide you, which is skin manifestation, which is lung manifestation, which is overlap, this alone is enough to say why I just need a myositis antibody panel, because this is enough to guide you. And this is why I say it has to be mutually exclusive, but it becomes difficult when you have 3-4 antibodies that are positive. So we also need to go back to the basic. I agree, and I also still feel that when you have someone with myositis, you should also do an ANA. And ANA here normally that we always look is your nucleolar, your nuclear, and your cytoplasmic. So we have patients where their myositis antibody, myositis associated antibodies are all negative, but their ANA pattern came back as nucleolar. And most of these patients are overlap scleroderma myositis. So when you know, so if you don't take your ANA and you just take a myositis antibody panel and everything comes back negative, you're not going to have the thought of myositis or scleroderma. But the moment we as rheumatologists, especially when we see this, I'll always make sure that we don't miss a scleroderma in this patient. And if the patient has a muscle weakness, CK is high, this is an overlap scleroderma myositis. So for me, nuclear is very important. Nuclear and cytoplasmic also will actually guide you on what kind of possible myositis antibody is there, like your necrotizing cytoplasmic, but for us it's normally nuclear. So I think Dr. Fatima also agree with me in this. Yeah. Okay. So as was already mentioned before, I think by the first two speakers as well, they've already talked about the classification criteria, and you can see that from here, this is a very nice picture because it actually shows how the classification criteria has evolved over the years. It started off with the famous Bohan and Peter in 1975, and that time it just tells you this is dermatomyositis or polymyositis. Is it definite, probable, or possible? And that was in 1975, and then subsequently in 1995, Tonito came out with another classification for polymyositis and dermatomyositis, and then later Connors and Solomon came back with your antisynthetase as well, and then where else? And then Griggs in 1995 for inclusion body myositis, where they came up with also probable, definite, and possible for inclusion body myositis. And then in 2014, the European Neuromedical Conference, actually in 2004, that's when actually they brought in an immune-mediated necrotizing myositis, and with your HMG and SRP antibodies. And finally, in 2017 was your EULA ACR criteria, where they actually spoke about your Jo1 antibody. But you can see from here how all the antibodies actually play a very important role in diagnosing myositis. So this is your Bohan and Peter classification, as Prof. Azrul mentioned earlier. And this is also your Tanimoto criteria as well in 1995. So this is our EULA ACR classification. So EULA ACR classification, the limitation of this classification is they only included Jo1 antibody. And as you've seen in the previous slide, there are many antibodies there. So when you don't have a Jo1 antibody, but you have a HMG-CR antibody, and most of the it's safe to say that necrotizing myositis, they do not come with cutaneous manifestation. So if you're going to use the myositis classification criteria, you're going to get a 0 scores for all the skin manifestation. You're not going to get a Jo1 positive there. So your scores are going to come down very low, and then someone's probably going to say, nah, this patient does not have myositis. So that's why at the end of the day, that classification criteria is something that we hope it's at the back of our mind, but at the end of the day, clinical assessment is very important. Your blood results and your examination is very important. You go back to your basics still. So this the clinical manifestation for all our myositis patients. So you will see your typical dermatomyositis, they have the Gottron papules. Your Gottron cells, papules are papules, macules, it will be your Gottron signs. Heliotrope over your periorbital region, your V sign on your anterior chest, and your shawls around your shoulder. Holsters will be on your thigh, the rashes. And they will always come with proximal muscle weakness, which is your neck flexion, shoulder abduction, and your hip flexion. Whereas inclusion body myositis, they come with actually distal weakness as well, proximal and distal weakness, your finger flexional weakness. And then you will also have, when the myositis is very bad, they will have involvement, bulbar involvement, so they will have dysphagia as well, all right? And then your ILD as well, and then your Raynaud's phenomenon, so your vasculopathy is also there. Your cardiac manifestation, yes, you can see that, especially in SRP. You can also see that in overlap myositis with scleroderma. Many will wonder when you come with a very high CK myocarditis, they'll think is it scleroderma, but at the end of the day, scleroderma is more of vasculopathy and fibrosis. So actually it is your myositis causing the myocarditis as well. So how do you how do you diagnose someone with myositis? At the end of the day, it always goes back to your basics. You have to examine the patient, see which see which is the muscle weakness. Is it proximal? Is it distal? It's always symmetrical. You cannot say someone has myositis only on the right side. It's always symmetrical. It's symmetrical muscle weakness. And then your rashes. You have to make sure that this is a dermatomyositis rash and not an SLE rash. Okay? And once you've already got the examination, clinically, you can already, just by examining the patient, you should already have a rough idea what kind of myositis. Is it a myositis with lung involvement, or is it just cutaneous involvement, or is it just arthritis involvement? So your blood results to support you will be your CK, your myositis antibody, and your associated antibody panel as well, inflammatory markers. So MRI. So normally we also do our myositis MRI of the thigh to look for inflammation. Do we send all patients newly diagnosed with myositis for MRI? No, not necessary, because you already know clinically and you have a high CK that is already there to guide you. Where MRI is important is, say you treated someone with myositis and they still have residual muscle weakness. So you want to know, is this residual muscle weakness due to ongoing inflammation, or is it already chronicity? So is it all just fatty atrophy changes? Because that will guide you in your management. I'm sure if it's a chronic changes, you do not want to be giving them continuous steroids or pulsing them, you see. So that's where actually your MRI plays an important role. So biopsy, as I said, we are actually moving away from muscle biopsy. But if you have someone who's not responding to your treatment, this is where you send them for a muscle biopsy. So there are quite a few cases where they do not have any positive antibodies, so we label them as seronegative polymyositis. But over the years, 10 years later, they start to develop new features. They probably will say they'll probably have weakness in their fingers. Okay, so when they start having new features, these are the patients you should send for muscle biopsy. You should definitely send patients for muscle biopsy if they are seronegative, because at the end of the day, the muscle biopsy will guide you what kind of myositis is it. Is it an inclusion body myositis? Is it a necrotizing myositis? Or is it a dermatopolymyositis? Because all of them have a different management. All right. And then your added assessment will be like your HRCT for your lung involvement, your EMG for someone that you suspect has myopathy, so they will do EMG. So this is a muscle biopsy. So when we send patients for muscle biopsy, these helps us guide us in what we want to look for. So you must always remember, like in general, your necrotizing myositis, your inclusion body myositis is always a CD8 predominant infiltrates. Necrotizing myositis, they're just a lot of necrotic tissues, very, very minimal infiltrates. Actually, they should not have any more inflammatory infiltrates in a necrotizing myositis. So when you see that kind of biopsy, you already know, oh, this is necrotizing. This is inclusion body myositis. These are extra markers that they do to say that whether this is inclusion body myositis or whether it's something else. All right. So in general, your antisynthetase and your dermatomyositis is always perivascular perimycal infiltrations, whereas polymyositis in general is more of endomycal infiltration. So treatment of idiopathic inflammatory myositis, actually it is challenging. It is really challenging because we do not have a proper guidelines that tell you this is your first line management, this is what you should give. So what we do is, first of all, you need to make sure the diagnosis is correct. Okay, you need to make sure that this is an inflammatory myopathy. It is not some other kind of myopathy like genetic myopathy, metabolic myopathy. We had a patient once when I was in UK, came in with proximal muscle weakness. He was also a bit on the overweight as well. CK was high, but myositis antibody all was negative, so naturally they send him for biopsy. And when we looked through the biopsy, it was actually a lot of cholesterol deposits inside. So he was actually a cholesterol myopathy, you see. So at the end of the day, you need to make sure that your patient is an inflammatory myopathy and not other kinds of myopathy. Like I said, sometimes the biopsy, you will see some sort of inflammation, like that cholesterol also had a bit of inflammation, but you had predominant cholesterol deposit. So if you just see inflammation alone in the biopsy, does not necessarily mean it's purely inflammatory myositis. And whenever your patients do not respond to your treatment, you must always send them for a muscle biopsy. We had in Selayang recently a patient with HMG-CR. He was quite refractory, we actually gave him, he came in with dysphagia, so we had to give him IVIG, and then we gave him, the first line we gave methotrexate and steroids, but his CK was still hovering around 5,000. We gave him cyclophosphamide, 5 cycles. It did come down, but it was still 1,000, still quite high for us. I mean, I would say it's still quite high. So at the end of the day, his HMG-CR antibody was strongly positive. But at the end of the day, we were wondering, are we in the right diagnosis? Was it correct? So we actually sent him for a muscle biopsy, and yes, it did confirm it was a necrotizing myositis. So we actually gave him 3 cycles of IVIG, changed it from methotrexate to MMF, cycled him, and with the plan of giving Ritux. And actually now his CK is down to about 350. So this kind of patients, when they take a long time to respond, it's always good to send for a muscle biopsy just to confirm your diagnosis. So when we assess a patient, like how in rheumatoid arthritis we have a specific assessment, we use our DAS28 score to calculate and see whether you're high disease, you're moderate disease, or you're low disease. So for myositis, when we see someone with weakness, you need to ask, is this chronicity? Is this patient been weak for 10 years? Or is this something very acute? All right? So normally if it's acute, your CK will be very high. If your CK is normal and it's still weak, then it's likely chronicity, and that's where your MRI will help us showing whether it's more atrophy changes or is there any inflammation. And pro-prognostic factors also will guide you in your management, especially if it's a TIF1 gamma that comes in very bad. You need to look out for the cancer, what cancer it is, screen hard for malignancy. So for them, those kind of patients, if it's related to malignancy, we can help treat them, but the ultimate treatment is their chemotherapy. But we can help with the bulbar symptoms by IVIG, we can help bring down the CK, the muscle weakness, by giving immunosuppressant. But at the end of the day, to make sure that they are completely better, I mean, at least 80% better, is they have to go for their chemotherapy. So patients normally when they come with dysphagia, that's not a good sign. You know already their myositis is quite bad because it's already bulbar involvement. Cardiac involvement is actually, most of them when they come with cardiac involvement, it's normally quite bad, and not many of them actually survive. So to say someone is treatment success, you have to look by improvement in their major manifestations. So if they came with predominant muscle weakness, they could not even get up, they're pretty bed, they're just bed bound, and now they're actually coming in and they can stand up, that's already a good sign for us already, you see. So improvement by muscle strength and their skin rashes, or depending on their organ. So if it's ILD, repeated HRCT will show whether it's improving already. So when we send patients for MRI, we will look at your T1. So this will show us a lot of atrophy. All this whiteness are all fatty atrophies. Means it's already chronicity, means the inflammation is not active. When you see this kind of patients, which normally you tend to see in inclusion body myositis, there's nothing much you can do. All right. Whereas when you see there's ongoing inflammation here, then you know this patient's myositis is quite active. If there's more inflammation and very minimal atrophy changes, you still treat as an active myositis. So how we assess patient is we actually use core sets measure. So this is very important in UK, and especially if you're doing clinical trial, you need to have your core sets inside. So your core sets will be the physician assessment on a scale of 1 to 10, how I feel the patient is now compared to baseline over the past 1 month, and also global activity. Muscle strength, we use the MMT8 score, which is 8 muscles that we are looking at, the total score of 150. Physical assessment, which is using your HAQ score, which is a scale to 0 to 3. And then your laboratory enzymes, which is your CK. Normally we just use CK here. So sometimes when you see ALT, AST is very high, many of us will be a bit worried about the immunosuppressant. But for me, I will say it's actually muscle origin. So I prefer you take a GGT. If your GGT is normal, then your raised ALT, AST is just muscle origin, and I will not stop or reduce the immunosuppressant. So extramuscular disease, so you need to see what are the extramuscular disease that are involved. So in 2016, for clinical trials, they actually came up with the total improvement score. This is actually to help guide in clinical studies, you see. So when they say there's improvement, it's like your ACR 20, 50. So this also is more or less the same. Minimal improvement is just 20%, moderate improvement is 40, and major is 60. So we normally use our calculator. So this is actually more for clinical trial. But it's also good to guide you, especially for your patients that come in the first time and when you see them the subsequent. So this is our muscle assessment. It's called manual muscle testing, MMT8 score. So we do only 8 muscles, which is your neck flexure, your deltoid biceps, your gluteus maximus, medius, and your quadriceps. Then the distal muscles, we do the extensors and your ankle dorsiflexors. So neck alone is 10, and then you got your right side altogether 70, left side 70, so overall it comes to 150. So this is your MMT8 score, which is upon 150. Most of the neurologists, when they assess myositis patient, they will do MMT8 score because actually they are looking more for inclusion body myositis. So inclusion body myositis, you must remember it's a lot of flexor weakness first. So that's why their MMT8 is actually 26 muscles. So they will do MMT8 score, but it's a bit more tedious and time consuming in the clinic to do 26 muscle assessment. But this, you should do this if you suspect inclusion body myositis. And so when you say what are the score, when you say someone, you're giving them a score for gluteus maximus, a score of 8 upon 10. So what is 8 upon 10? So this is what we use, Kendall score. So Kendall score is a score upon 0 to 10, which is actually pretty much like your MRC score, which is up to 5. So this will tell you what are your scores. So if you're moves through partial range of movement, your Kendall score is 1 out of 10. If they are able to hold against moderate to strong pressure, it's about 9. Okay. And for patient global assessment, it's upon 1 to 10. So we will give the score and tell patient, okay, overall, how do you feel on a scale of 1 to 10? And they will just roughly tell you. So sometimes, most of the time, they will always say they're 5, 6. I've not seen a patient, even though they're so well, they will still say they're 3, they're in remission. But actually, when you look through those 3, it's mainly fatigue. You see, and that's something we have not explored yet also in myositis, you see. So physician global assessment, this will be a scale also 1 to 10 for us. And this is all part of your... so extramuscular disease activities, it's a MD8AT. So it has all the systems here. You have your constitutional disease, you have your cutaneous, you have your skeletal muscle, you have GI involvement, you have lung involvement, you have cardiovascular involvement, and then if there's other disease, you will just rate them there as well. So you can see how extensive this assessment is, you see, so you know you're not going to miss other organs. And this is your hex care, your physical assessment for patients. And just like SLE patients, we have they have a score just like this. For us, this is classy score. Ours is cutaneous dermatitis score. So here also, if you see, you have activity and you have damage. So even skin also, there is chronicity when you assess a patient, you see. So I think one of the case I'll show you how he presented with. So here also, and why this is also quite important is because some of them, when they come with very bad cutaneous manifestation, they actually can look like as if it's SLE. They also have alopecia as well, you see. Yeah. So like I mentioned, there's no proper guideline to tell you to be definite what is your first line management, what's your second line management. But in general, this is what we always do. Steroids is definitely the first line. It's a cornerstone of your management for myositis. Then we do not want them to be on steroid for a very long time because of its potential side effect. So this is when you start them on immunosuppressants, which is your methotrexate and AZA. Normally these are your first line. Then you can consider MMF. Those with very bad, if a patient comes with dysphagia, then you actually have to give them IVIG. And some patients with very bad cutaneous involvement, actually they improve with IVIG. Retux is normally for our refractory disease. So this is one of the guidelines where they said that to guide you on how to manage. So steroids, your first line will be your methotrexate or AZA. Your second line is actually, in UK they actually combine methotrexate with AZA, but I think combining two immunosuppressant, the risk of infection is quite high, so you have to be careful if you want to combine your immunosuppressant. Not second line will be your MMF or your cyclosporin or tacro, and then your third line. Physical therapy is actually an important role. You have to make sure while they're on treatment as well, they have to build up their muscle strength as well. So they still have to go for physiotherapy as well. So for those in refractory myositis, refractory myositis, depending on what antibody it is. So if it's an anti-synthetase, normally we will actually give them MMF, or depending how bad, we should really cut from MMF to Retux and then put them on a maintenance of MMF. Sometimes depending on budget involvement, if there's not enough budget, then we should really go cyclophosphamide. And then your HMG-CR as well. So normally IVIG can be used for refractory myositis, dysphagia, very, very bad cutaneous. IVIG actually works well for them. So these are our clinical challenges that we actually have. So diagnostic complexity. So as you know, it's a heterogeneous presentation. So we tend to have overlap with other features as well. So when you have an overlap, it becomes difficult. So this is where you might want to consider muscle biopsy as well. Delay diagnostic is actually a very it's most of the time. Most of the patients, they actually have the symptoms 1 year before presenting to us, and before they actually come to us, they've probably gone to a GP or any private clinic, and the signs are not picked up until it's quite severe. So inconsistent access. So like what Dr. Ani said, it's only now done in Selayang. We don't have it in other government hospitals. So like if you're in Kelantan, you send it to Selayang, your results come back 4 weeks, 5 weeks. But if you're someone who really needs the myositis antibody to guide you on your management, if the patient can afford, they normally do it in private. So if you do it outside, they get it within 5 working days, including the HMG-CR. So histopathology pitfall. So sometimes when you send them for muscle biopsy, if they don't biopsy the right side, they take a side that it's already just chronicity, fatty changes, then you're not going to see anything. All right. And then sometimes these are most of the time can be the real scenario where it's difficult to differentiate your immune-mediated necrotizing myositis with your inclusion, because both are actually CD8, but normally necrotizing, there'll be very, very minimal infiltrates and predominant necrosis. Another problems where we have is dose refractory. How you want to manage them if they're refractory. If there's already refractory in their management, normally you want to give them Ritux, and sometimes budget is an issue. Even IVIG, giving them, like in UK, they actually give monthly 6 times IVIG. See, I guess, yeah, they can afford. But for us, if I want to give IVIG, I have to be absolutely sure that it's really indicated, you see. So our practice here in UK is very different, you see. And most of the time, patients tend to relapse when you start bringing down their steroids. So when they start relapse, that's where you need to think of adding on a biologic, whether it's a Ritux, and putting them on maintenance of MMF. It's not that if, say, someone, like just recently, a patient with antisynthetase, the lungs are good, but muscle weakness, she required metopret twice, and she's already on a MMF of 1.5 gram BD. So these are the kind of patients that you need an add-on for them, you see. Extramuscular involvement, if the lung is very bad, especially your MDA5, it's going to be a bit difficult to manage them. Cardiac involvement, most of the time, this is the most frequent scenario. They're always underdiagnosed. So long-term management monitoring assess, we don't have a proper validated biomarkers to track disease activity. We go clinical by your CK, and if it's lung, we do 6 monthly, 8 monthly HRCT. Of course, we go by their symptoms. So we don't have anything to really tell us this is what you have to do. There is always a diagnostic and treatment gaps between high and low resource regions. Okay, so like I said, myositis panel all comes to Selayang. Even HK also sends it to Selayang. Yeah. So limited access to biologics, IVIG. So with this limited access, it's going to be difficult to treat your patients as well. And a lot of times we always forget CK is normal, and we always say they're in remission, but we have not addressed the fatigue. You also have to also address the muscle endurance as well, and quality of life. So these are the things that we tend to overlook. We're always just looking at, oh, muscle, you're walking now, it means your power is good, and we do not. So that's why they always give themselves 3/10 or 4/10, although they are in remission. Yeah? So emerging therapies now, there are a lot of new things that are coming. I had the pleasure when I was in UK to be in this clinical trial as well. Your tyrosine kinase 2, your JAK inhibitor, this clinical trial also was involved. So there's also CAR T cells as well. So these are all new things that are coming, but I'm not sure when it will come to Malaysia, but it's always good to be aware of. So when I was in Salford Royal Hospital, these are the clinical trials that I joined in. So we had Neptuna, which is your toll-like receptor 7 and 8 antagonists. This mainly for patients with dermatomyositis, polymyositis, confirmed with biopsy. So these are your core sets to include them. What are the active diseases that you can include them? So we also had tyrosine kinase and your JAK inhibitor. Now, the JAK inhibitors actually worked very well for cutaneous DM. There was muscle improvement as well, but more significant improvement in the skin from those patients that I saw. You have your Arjank and Spiria, which is both also with the aim of reducing your immunoglobulin IgG level as well. So this also was good, but I only saw one of each, so I can't really say much whether they improved in it. So CAR T cell therapy is also something that's very interesting, but I do not know when it will come here. I think there was a mention that they might want to bring it down to Malaysia, but Dr. Sherin said she'll get back to me on it. But yeah, so CAR T cell therapy basically means like there's a process for it. So you take the patient's blood and you collect the T cells from it, and you have to send those T cells and it's engineered in a lab where they express the CAR, and then later the CAR allows the T cells to recognize and bind to specific markers on the surface B cells, which are the source of antibodies in myositis. So when you do CAR T cell therapy, it's basically a complete destruction of your B cells. And basically the process is aimed to deplete disease-causing B cells and more like a reset for the immune system. So like rituximab, we always say it's a peripheral depletion of your B cells. Omecuzumab is a bit more deeper, but this is a more complete depletion of your B cells. So this is how it's done. You collect the blood, and then you isolate. You have to have a specific lab to do it. So that's why I think it's going to be very, very difficult here. I think in UK they were actually sending it to US. So we can't send it to US. It's far-fetched here. So I do not know whether it will really come here. But there was 2 talks that I attended, and they showed patients with refractory myositis, and they actually worked very well with CAR-T. So come to the end of it. So I mean, based from this talk, you can understand that it is a heterogeneous spectrum of disease. Autoantibodies actually redefine clinical classification, and it's all targeted therapy to improving our patients' management. And diagnostic precision is very important, and you must remember, you must always think of quality of life in the long-term outcomes. Okay. Yep. Thank you.
Okay, thank you, Dr. Tara, for the wonderful talk. Okay, are there a question from the floor or sharing session? Yeah, Dr. Masita, please.
Thank you, Dr. Tara, for sharing the experience managing all the myositis cases. Since we have half an hour before
Oh
lunch
dear,
break,
I didn't realize I went
so I have 4 questions for you.
Can.
To buy time. Is it okay, audience? Okay, 4 questions. Okay, the first one about MDA5 myositis, because I think MDA5 myositis very hard to our heart lah, for all our clinical microbiologists, because our colleague passed away due to that. But for your experience, I can see 2 cases just now responded very well with the cyclosporine, right? This is based on these 2 cases. But for your own experience, along your experience managing MDA5 myositis, how many percent actually recover, and how many actually not really survive?
Okay.
This is my first question.
Okay, so I answered the first question before I forget it. Okay, so MDA5. So when I was in UK, I came across a few MDA5s, and actually, Prof. Chinoy actually told me that MDA5 now, they come with a few predominant features. They can either come with predominant ILD, predominant vasculopathy, means very bad Raynaud's. They can have GI vasculopathy as well, and they can come with just very bad arthritis. So, and in terms of ILD, you have 3 types of ILD. They can come with an ILD that is very mild and they don't progress. They can come with an ILD that very gradually over years slowly progress, but when they progress, you pick it up. And they come with ILD that is very rapid, means they come today, their symptoms is only 1 month, and by the 2nd month, they're already bedbound, and they normally don't make it. So for this patient, when you want to ask, so I'll go straight to the lung involvement. So if it's a lung involvement, if it's a rapidly progressive ILD, in Malaysia, I have not come, that was one rapidly progressive, but she actually responded quite well, and she was actually had infection as well. So we treated infection, we started a cycle, she did respond well. But in general speaking, some of my colleagues that did with me in UK from China, for them their MDA5 are very bad. They go straight with plasma exchange. For them, sometimes they consider plasma exchange. Sometimes they go triple combination where you pulse them. You can also give cyclophosphamide or Ritux, and you add on tacrolimus together. So if it's a very rapidly progressive ILD, we will actually co-manage with the respiratory physician. So at the end of the day, I really feel one thing that I can take take back from UK and bring it back here is one very important thing is MDTs. MDTs are very important, which I actually personally want to start in HKL, where I want to get involved the pathologists, your histopathologists, your immunologists, of course rheumatologists and neuromedical as well. So when you have an MDT, depending on the organ involvement, it is a shared decision, because you must understand when someone comes with a very rapidly progressive ILD, you must understand you need to start their immunosuppressant fast. So it's either you pulse them straight away and start them with cyclophosphamide or rituximab, and if it does not improve, you go ahead with plasma exchange as well. So for me, MDT is a very important thing, and of course I hope to start there in HK, and if we do start, you'll be informed as well. So back to your question, Doctor, it will depend on how aggressive was the ILD, and it will be a combined decision with the lung doctors as well, respiratory physician.
So you cannot say how many percent is from your own experience?
From my own experience, no, because rapidly progressive, I only came across one in the UK. And in UK, when it's predominant lung involvement, theirs is purely managed by respiratory. They refer to us just to get the retux.
My second question about the HMGCR with statin just now. So how you manage that? Is it because it's considered associated with statin, right? The myositis. Yeah. Can you share your experience how we manage?
Okay. So HMGCR myositis, it's commonly associated with those with statins, and we can actually see that also with those without statins. And if you dig hard from their history, they have history of taking traditional herbs and all. So there are association with those medications as well. So in general, if you have someone with HMGCR myositis, statin-induced myositis, they can never be back on statins. And most of these patients are always high CV risk. That's why they want statins to begin with, right? So for these patients, you will have to refer them to the endocrinologist or cardiologist for PCSK9 inhibitor. They cannot be back on statin because it will come back again. HMGCR, if you pick it up early, I feel they are treated quite fast and they're responsive. But when you don't pick it up early and they only been diagnosed 1 year later, then it's a bit difficult. We had one patient that was referred from Sungai Buloh, Chinese elderly lady. So she came in with very bad muscle weakness. She was pretty much bedbound. CK was about 8,000, 9,000. But they did the myositis antibody panel, which naturally all came back negative. Because she was about 58, they suspected this could be a malignancy associated problem. So they subjected for upper and lower scope. So when they did a colonoscopy, they saw a lot of polyps. The polyps came back as tubular adenoma. So naturally, they labeled her as paraneoplastic myositis. And CK was 8,000. They referred her to us when we saw her. But one thing good is they did a muscle biopsy. So when they referred her to us in Selayang, the muscle biopsy was not available. So we have given the plan, okay, bring down the steroids, start MTX, and we will see her in 6 weeks' time. But when she was discharged, she was not referred back to us because she was already bedbound. Coming for a follow-up it was difficult for her. And 2 months later, she was admitted for non-STEMI in the hospital, and she was started on statin and all. And 1 year later, she came for follow-up, still on a wheelchair with mild dysphagia to solid liquid she could tolerate. And so when I saw her CK was about 5,000, and then I saw her biopsy results. So this is a very good case because everyone assumed this is a paraneoplastic myositis because of a tubular adenoma. But her muscle biopsy actually showed features of immune-mediated necrotizing myositis. And she has been on statin and not stopped from statin. In fact, the statin dose was increased from 20 to 40. So, so these are kind of cases where you must understand. So naturally, there was a debate. No, this is still paraneoplastic. So you know what? We just sent off the HMGCR panel, which came back strongly positive. So for her, we had to IVIG her, we cyclophosphamide her, and she improved. Her MMT8 score when she first came to us was 82 over 150. Once she's finished her cyclophosphamide, it was about 132 over 150. You need to understand she was 1 year bed bound. So there's a lot of chronicity there already. In UK, they also have the HMGCR, their lab actually runs the titer value as well. But we do not know the significance of the titer. If it's high, what is it? Whether it's significant. And there's one patient in UK that I had an opportunity to also work with. He was refractory to rituximab, cyclophosphamide, MMF, methotrexate. They started him on abatacept, but he eventually developed dysphagia. He became worse. So we actually started him on plasma exchange. So plasma exchange, you're just basically taking out all the antibodies. So his CK from 5,000 came down to 20, 50, and it was normalized. But after that was more of rehabilitation and being. So plasma exchange is sometimes the last option, depending on how severe. It is not in any guidelines, plasma exchange for myositis, but if you look in a few other countries, very aggressive myositis, they actually go for plasma exchange. And HMGCR statin-induced myositis, I feel a lot of patients, they tend to start statin immediately straight with 40 and then straight going up to 80, but you shouldn't. You should always start it with a very low dose because you do not know. They can develop the statin myositis sometimes 5 years after starting statin. Some people 1 year after. So it's very hard to predict.
Yeah. So my third question and fourth question actually can be answered one maybe, because for my third question about the muscle biopsy, who actually performed the muscle biopsy, and is it how the muscle biopsy is performed? And continue with that, my fourth question, is there any possibility to develop the CPG for myositis in Malaysia? I know there is a CPG for SLE. I think it's good to have that with the MDT. Just now you mentioned about the multidisciplinary team. I think this is the output of that MDT to have a CPG. Thank you.
Thanks. Okay, so muscle biopsy in Malaysia is generally done by the orthopedic surgeons and sometimes even the plastic surgeons. In UK, the muscle biopsy was actually performed by the neurologists, but it's actually a blind method. So actually, I joined in to see the muscle biopsy. It's a bit scary because it's just an outpatient appointment. They come. They will feel for your vastus medialis lateralis, so they ask you to stiff your leg, and the prominent muscle they see, that is your muscle. Okay, we will numb this area. You might feel a bit of numbness or tingling, but if you feel a lot of tingling, you must let me know. It might be the nerve you're cutting. But they've not had that complication, but it's a complication you need to tell them because it's a blind method. But ideally, when I looked at it, of course I assisted 2 or 3, but I think it's not feasible here. I don't think so. I would want to take the risk of suddenly someone having a foot drop and it's because of a muscle biopsy, you see. So patients where the muscle biopsy came back inconclusive, they actually send it to the plastic surgeons in UK to do it. So I think the availability to do a muscle biopsy, I think most of the time our orthopedic surgeons are happy to do it, but it's getting it interpreted. I think we only have one person in only HKL does the muscle biopsy review. So I think if you send it from other hospitals, it all comes to HKL, and if it's in university, it goes to UM, I think. Yeah, so that's why it's getting the muscle biopsy is not an issue, but like people, if they're saying you're in Kelantan, it's difficult to send it by transport. There's a certain way you have to send it, certain time also, and Kelantan, Friday, Saturday is their weekend, and Sunday they tend to do the procedure, and we are off on Sunday. So that's where a lot of shortcomings come from there. Your last question, CPG, that's it's. Well, I think in order to do a CPG, we must have more patience, and I really feel that we should actually start on a myositis registry. It is a project that I'm keen on, looking forward to start, but it's not going to be easy. But in a myositis registry, you will already have, because at the end of the day, you need to find out why are we having patients who are not mutually exclusive myositis and they're having 2, 3, and some of the antibodies are like Me2, PML75, and TIF1 gamma. Those are all different kind of myositis issues, you see, so we don't know why they are having. So it's good to look into how many patients in our populations are having those and how many comes with mutually exclusive, biopsy results, management, and then from there, when you have a good case of all this, then I think it's good to sit and then have a CPG. Like I think Brazil have their own guidelines, British also has their own guidelines, and Japan also has their own. But we don't have a universal, because it's not many patients. Not many, it's very hard to say, but I think it's underdiagnosed. But it will be a great task. But something that looking forward to, but will be a challenge. But of course, today is an opportunity, so I met everyone, so we will be in touch. Yeah.
Okay, I'll just ask a question from the audience. Okay.
Just a comment, not a question. But you can see that from this talk, from Dr. Tara talks just now. So this myositis patient can present anywhere actually. Can present in primary care clinic, can present in emergency department, for example. So I think it's important to create awareness. Yeah, like the case that you shared just now.
Yeah.
So it's important for the doctors, especially young doctors, actually to recognize the signs and symptoms of the myositis, so that will trigger them to investigate for myositis. Because I think rheumatologists will receive someone that they think of the myositis, then they refer to you.
Yes.
Maybe there are some patients that present atypically, maybe will not be referred to rheumatologists, for example. Yeah.
Yes.
I think it's important to create the awareness. I think that's why we have this National Autoimmune Day. I think,
Yeah, that's actually very important. Yeah.
Thank you, Dr. Tara and the audience, for the very interesting and insightful Q&A session. I would like to request Dr. Tara to remain on the stage and invite Dr. Masita for the certificate ceremony. Distinguished guests, ladies and gentlemen, next in the agenda, we have come to our lunch and prayer break. You are welcome to lunch, which will be served at Cafeteria Sihat Level 5. So our Muslim attendees, the prayer rooms are located at Level 3. Gentle reminder to please come back to this auditorium at 2 p.m. to begin our next session. Thank you and have a nice break. Okay.
The Pathological Institute of Kuala Lumpur was established in 1900 by the Resident General of British Malaya, Sir Frank Swettenham. Its aim was to promote the health status of the local population and to explore the great and unknown field of tropical medicine. The institute was renamed as the Institute for Medical Research, or IMR, a year later. Initially, the focus of this research was on beriberi and malaria. Subsequently, it goes expanded into the causes, treatment, and prevention of a variety of tropical diseases such as cholera, smallpox, leprosy, tuberculosis, typhoid, filariasis, dengue, scrub typhus, and nutrient deficiencies. IMR was formerly located before moving to Shah Alam recently in a new research complex together with other research institutes under the Ministry of Health Malaysia. This specially designed building is enhanced and equipped with advanced and high-technology machines and instruments. It is now recognized to be a high-impact center in biomedical research at national and global level, with the presence of Biosafety Level 3 or BSL-3, Arthropod Containment Lab or ACL, Good Laboratory Practice GLP, and Biomedical Research Core Facility BioRCF. Upon independence, IMR became the research arm for the Ministry of Health Malaysia, where research conducted has been aligned with the country's research priorities. In more recent times, research at the IMR has progressed in gathering in-depth knowledge of allergy and autoimmune diseases, primary immunodeficiency diseases, and the development of allergy test kits. The IMR has developed its expertise in nutritional biochemistry, where there is active involvement in preclinical studies on metabolic syndrome, diabetes, cardiovascular health, and endocrine-related diseases. The Institute's iodine test kit is used nationwide for monitoring purposes under the Iodine Deficiency Program. The dawn of the next millennium encountered many issues that were related to contaminants and pollutants in the environment and in the workplace, along with their impact on human health. Thus, in a forward-thinking manner, IMR conducted vulnerability assessment on impacts of climate change on health and health delivery. Cancer research at the IMR has vigorously looked at diagnostics, prevention and early detection, as well as identification of novel biomarkers and targeted therapy for precision medicine. For this, the Institute has been equipped with a specific pathogen-free or SPF animal facility and biobank. The Institute has established a unique interactive e-database called Global Information Hub on Integrative Medicine, or more commonly known as GlobenMed, which strives to become a referral source on traditional and complementary medicine, T&CM. In addition, herbal research activities are focused on the evaluation of herbal extracts under certified GLP conditions, assessing efficacy of herbal products using in vivo as well as in vitro systems, phytochemical analysis, as well as structure elucidation. The IMR has continued to provide in-depth research related to infectious diseases, especially during outbreaks, and it is the reference center for COVID-19, Zika, dengue, influenza, leptospirosis, melioidosis, and malaria. Epidemiology.
Allergy and Immunology Research Center, AIRC. Founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading center for immunological research and specialized diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Center dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunization. In 1930, this section was designated the lymph station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral centre for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI-spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories: anti-aquaporin 4 antibodies, anti-N-methyl D aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's, and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Programme for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
Autoimmune diseases, when the body attacks itself. Normal immune function is to protect the body from harmful pathogens, produce antibodies that target foreign antigens, and distinguish between self and non-self cells. In autoimmune conditions, recognition system malfunctions, healthy tissues mistakenly identified as threats, antibodies attack the body's own cells. What causes autoimmune diseases? Genetic factors, strong hereditary component with certain autoimmune conditions running in families. Specific gene variants increase susceptibility. Hormonal factor, women are 2 to 3 times more likely to develop autoimmune diseases than men, possibly due to hormonal differences. Environmental triggers, certain infections, exposure to chemicals, medications, and other environmental factors may trigger autoimmune responses in genetically susceptible individuals. Despite extensive research, the exact cause often remains unknown and is likely a complex interplay of multiple factors. Examples of autoimmune diseases: rheumatoid arthritis, attacks joint linings, causing painful inflammation and potential damage to joints, lungs, and eyes. Type 1 diabetes, immune system attacks insulin-producing cells in the pancreas, affecting blood glucose regulation. Multiple sclerosis damages the protective covering of nerve cells in the brain and spinal cord, disrupting communication signals. Common symptoms in autoimmune diseases: persistent fatigue, overwhelming exhaustion that doesn't improve with rest, joint and muscle pain ranging from mild discomfort to severe, debilitating pain, skin problems, rashes, sensitivity to sunlight, or changes in skin texture and appearance, low-grade fever, persistent slight elevation in body temperature during disease activity, swollen glands, digestive issues, abdominal pain, bloating, diarrhea, or changes in bowel habits, brain fog, difficulty concentrating, memory problems, and cognitive challenges. Relapsing remitting pattern, symptoms often fluctuate between periods of flare and remission. However, the symptom profile differs across various autoimmune diseases and among individuals with the same condition. Diagnosing autoimmune diseases: gathering a thorough patient history, including symptoms, timeline, family history, and environmental exposures. Conducting a physical examination to identify signs of inflammation, rashes, joint swelling, or organ dysfunction. Performing blood tests for autoantibodies, inflammatory markers, organ function, and complete blood counts. Referring to specialists such as rheumatologists, endocrinologists, gastroenterologists, or other relevant experts based on the symptoms. Nevertheless, diagnosis can frequently be challenging and may require several years due to overlapping symptoms and the intermittent nature of numerous autoimmune conditions. Treatment and management. Goals: reduce inflammation, manage symptoms, prevent organ damage, induce and maintain remission, improve quality of life, minimize medication side effects. Medication: first line, corticosteroids, anti-inflammatories, immunosuppressant, biologics, targeted therapies, specific supplements, insulin, hormones, vitamins. Lifestyle modifications: anti-inflammatory diets may reduce symptom severity. Appropriate exercise maintains function and reduces pain. Stress management techniques help prevent flares. Sleep hygiene improves energy and immune regulation. Support systems: patient groups and mental health support can provide valuable emotional and practical assistance. Common misconceptions: autoimmune diseases are contagious. They're not. Symptoms are always visible, most are invisible. It's just in your head, symptoms are measurable, nothing helps, many treatments are effective. In conclusion, with proper knowledge, support, and healthcare, people with autoimmune diseases can sustain a good quality of life and manage their conditions effectively.
The Pathological Institute of Kuala Lumpur was established in 1900 by the Resident General of British Malaya, Sir Frank Swettenham. Its aim was to promote the health status of the local population and to explore the great and unknown field of tropical medicine. The institute was renamed as the Institute for Medical Research, or IMR, a year later. Initially, the focus of this research was on beriberi and malaria. Subsequently, it goes expanded into the causes, treatment, and prevention of a variety of tropical diseases such as cholera, smallpox, leprosy, tuberculosis, typhoid, filariasis, dengue, melioidosis, scrub typhus, and nutrient deficiencies. IMR was formerly located at Jalan Pahang, Kuala Lumpur, before moving to Shah Alam recently in a new research complex together with other research institutes under the Ministry of Health Malaysia. This specially designed building is enhanced and equipped with advanced and high-technology machines and instruments. It is now recognized to be a high-impact center in biomedical research at national and global level, with the presence of Biosafety Level 3, or BSL-3, Arthropod Containment Lab, or ACL, Good Laboratory Practice, GLP, and Biomedical Research Core Facility, BioRCF. Upon independence, IMR became the research arm for the Ministry of Health Malaysia, where research conducted has been aligned with the country's research priorities. In more recent times, research at the IMR has progressed in gathering in-depth knowledge of allergy and autoimmune diseases, primary immunodeficiency diseases, and the development of allergy test kits. The IMR has developed its expertise in nutritional biochemistry, where there is active involvement in preclinical studies on metabolic syndrome, diabetes, cardiovascular health, and endocrine-related diseases. The Institute's iodine test kit is used nationwide for monitoring purposes under the Iodine Deficiency Program. The dawn of the next millennium encountered many issues that were related to contaminants and pollutants in the environment and in the workplace, along with their impact on human health. Thus, in a forward-thinking manner, IMR conducted vulnerability assessment on impacts of climate change on health and health delivery. Cancer research at the IMR has vigorously looked at diagnostics, prevention and early detection, as well as identification of novel biomarkers and targeted therapy for precision medicine. For this, the Institute has been equipped with a specific pathogen-free or SPF animal facility and biobank. The Institute has established a unique interactive e-database called Global Information Hub on Integrative Medicine, or more commonly known as GlobenMed, which strives to become a referral source on traditional and complementary medicine, T&CM. In addition, herbal research activities are focused on the evaluation of herbal extracts under certified GLP conditions, assessing efficacy of herbal products using in vivo as well as in vitro systems, phytochemical analysis, as well as structure elucidation. The IMR has continued to provide in-depth research related to infectious diseases, especially during outbreaks, and it is the reference center for COVID-19, Zika, dengue, influenza, leptospirosis, melioidosis, and malaria. Epidemiology.
Allergy and Immunology Research Center, AIRC, founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading center for immunological research and specialized diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Center dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunization. In 1930, this section was designated the Lymph Station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral centre for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories. Anti-aquaporin 4 antibodies, anti-N-methyl D aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Programme for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
Autoimmune diseases, when the body attacks itself. Normal immune function is to protect the body from harmful pathogens, produce antibodies that target foreign antigens, and distinguish between self and non-self cells. In autoimmune conditions, recognition system malfunctions, healthy tissues mistakenly identified as threats, antibodies attack the body's own cells. What causes autoimmune diseases? Genetic factors, strong hereditary component with certain autoimmune conditions running in families. Specific gene variants increase susceptibility. Hormonal factor, women are 2 to 3 times more likely to develop autoimmune diseases than men, possibly due to hormonal differences. Environmental triggers. Certain infections, exposure to chemicals, medications, and other environmental factors may trigger autoimmune responses in genetically susceptible individuals. Despite extensive research, the exact cause often remains unknown and is likely a complex interplay of multiple factors. Examples of autoimmune diseases. Rheumatoid arthritis attacks joint linings, causing painful inflammation and potential damage to joints, lungs, and eyes. Type 1 diabetes. Immune system attacks insulin-producing cells in the pancreas, affecting blood glucose regulation. Multiple sclerosis damages the protective covering of nerve cells in the brain and spinal cord, disrupting communication signals. Common symptoms in autoimmune diseases. Persistent fatigue, overwhelming exhaustion that doesn't improve with rest. Joint and muscle pain, ranging from mild discomfort to severe, debilitating pain. Skin problems, rashes, sensitivity to sunlight, or changes in skin texture and appearance. Low-grade fever, persistent slight elevation in body temperature during disease activity. Swollen glands, digestive issues, abdominal pain, bloating, diarrhea, or changes in bowel habits. Brain fog, difficulty concentrating, memory problems, and cognitive challenges. Relapsing remitting pattern, symptoms often fluctuate between periods of flare and remission. However, the symptom profile differs across various autoimmune diseases and among individuals with the same condition. Diagnosing autoimmune diseases. Gathering a thorough patient history, including symptoms, timeline, family history, and environmental exposures. Conducting a physical examination to identify signs of inflammation, rashes, joint swelling, or organ dysfunction. Performing blood tests for autoantibodies, inflammatory markers, organ function, and complete blood counts. Referring to specialists such as rheumatologists, endocrinologists, gastroenterologists, or other relevant experts based on the symptoms. Nevertheless, diagnosis can frequently be challenging and may require several years due to overlapping symptoms and the intermittent nature of numerous autoimmune conditions. Treatment and management. Goals: reduce inflammation, manage symptoms, prevent organ damage, induce and maintain remission, improve quality of life, minimize medication side effects. Medication: first line, corticosteroids, anti-inflammatories, immunosuppressant, biologics, targeted therapies, specific supplements, insulin, hormones, vitamins. Lifestyle modifications. Anti-inflammatory diets may reduce symptom severity. Appropriate exercise maintains function and reduces pain. Stress management techniques help prevent flares. Sleep hygiene improves energy and immune regulation. Support systems. Patient groups and mental health support can provide valuable emotional and practical assistance. Common misconceptions. Autoimmune diseases are contagious. They're not. Symptoms are always visible, most are invisible. It's just in your head, symptoms are measurable, nothing helps, many treatments are effective. In conclusion, with proper knowledge, support, and healthcare, people with autoimmune diseases can sustain a good quality of life and manage their conditions effectively.
The Pathological Institute of Kuala Lumpur was established in 1900 by the Resident General of British Malaya, Sir Frank Swettenham. Its aim was to promote the health status of the local population and to explore the great and unknown field of tropical medicine. The institute was renamed as the Institute for Medical Research, or IMR, a year later. Initially, the focus of this research was on beriberi and malaria. Subsequently, it goes recently in a new research complex together with RCF. Upon independence, IMR became the research arm for the Ministry of Health Malaysia, where research conducted has been aligned with the country's research priorities. In more recent times, research at the IMR has progressed in gathering in-depth knowledge of allergy and autoimmune diseases, primary immunodeficiency diseases, and the Developing Deficiency Program. The dawn of the next millennium encountered many issues that were related to contaminants and pollutants in the environment and in the workplace, along with their impact on human health. Thus, in a forward-thinking manner, IMR conducted vulnerability assessment on impacts of climate change on health and health delivery. Cancer research and early detection, as well as identification of novel biomarkers and targeted therapy for precision medicine. For this, the Institute has been equipped with a specific pathogen-free or SPF animal facility and biobank. The Institute has established a unique interactive e-database called Global Information Hub on Integrative Medicine, or more commonly known as GlobenMed, which strives to become a referral source on traditional and complementary medicine, T&CM. In addition, herbal research activities are focused on the evaluation of herbal extracts under certified GLP conditions, assessing efficacy of herbal products using in vivo as well as in vitro systems, phytochemical analysis, as well as structure elucidation. The IMR has continued to provide in-depth research related to infectious diseases, especially during outbreaks, and it is the reference center for COVID-19, Zika, dengue, influenza, leptospirosis, melioidosis, and malaria. Epidemiology.
Allergy and Immunology Research Center, AIRC, founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading center for immunological research and specialized diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Center dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunization. In 1930, this section was designated the Lymph Station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral center for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories. Anti-aquaporin 4 antibodies, anti-N-methyl D aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Program for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
Autoimmune diseases, when the body attacks itself. Normal immune function is to protect the body from harmful pathogens, produce antibodies that target foreign antigens, and distinguish between self and non-self cells. In autoimmune conditions, recognition system malfunctions, healthy tissues mistakenly identified as threats, antibodies attack the body's own cells. What causes autoimmune diseases? Genetic factors, strong hereditary component with certain autoimmune conditions running in families. Specific gene variants increase susceptibility. Hormonal factor, women are 2 to 3 times more likely to develop autoimmune diseases than men, possibly due to hormonal differences. Environmental triggers, certain infections, exposure to chemicals, medications, and other environmental factors may trigger autoimmune responses in genetically susceptible individuals. Despite extensive research, the exact cause often remains unknown and is likely a complex interplay of multiple factors. Examples of autoimmune diseases. Rheumatoid arthritis attacks joint linings, causing painful inflammation and potential damage to joints, lungs and eyes. Type 1 diabetes. Immune system attacks insulin-producing cells in the pancreas, affecting blood glucose regulation. Multiple sclerosis damages the protective covering of nerve cells in the brain and spinal cord, disrupting communication signals. Common symptoms in autoimmune diseases. Persistent fatigue, overwhelming exhaustion that doesn't improve with rest. Joint and muscle pain, ranging from mild discomfort to severe, debilitating pain. Skin problems, rashes, sensitivity to sunlight, or changes in skin texture and appearance. Low-grade fever, persistent slight elevation in body temperature during disease activity, diarrhea or changes in bowel habits. Brain fog, difficulty concentrating, memory problems, and cognitive challenges. Relapsing remitting pattern, symptoms often fluctuate between periods of flare and remission. However, the symptom profile differs across various autoimmune diseases and among individuals with the same condition. Diagnosing autoimmune diseases. Gathering a thorough patient history, including symptoms, timeline, family history, and environmental exposures. Conducting a physical examination to identify signs of inflammation, rashes, joint swelling, or organ dysfunction. Performing blood tests for autoantibodies, inflammatory markers, organ function, and complete blood counts. Referring to specialists such as rheumatologists, endocrinologists, gastroenterologists, or other relevant experts based on the symptoms. Nevertheless, diagnosis can frequently be challenging and may require several years due to overlapping symptoms and the intermittent nature of numerous autoimmune conditions. Treatment and management. Goals: reduce inflammation, manage symptoms, prevent organ damage, induce and maintain remission, improve quality of life, minimize medication side effects. Medication: first line, corticosteroids, anti-inflammatories, immunosuppressant, biologics, targeted therapies. Specific supplements, insulin, hormones, vitamins. Lifestyle modifications. Anti-inflammatory diets may reduce symptom severity. Appropriate exercise maintains function and reduces pain. Stress management techniques help prevent flares. Sleep hygiene improves energy and immune regulation. Support systems. Patient groups and mental health support can provide valuable emotional and practical assistance. Common misconceptions. Autoimmune diseases are contagious. They're not. Symptoms are always visible. Most are invisible. It's just in your head. Symptoms are measurable. Nothing helps. Many treatments are effective. In conclusion, with proper knowledge, support, and healthcare, people with autoimmune diseases can sustain a good quality of life and manage their conditions effectively.
The Pathological Institute of Kuala Lumpur in 1900 by the Resident General of British Malaya, Sir Frank Swettenham. Its aim was to promote the health status of the local population and to explore the great and unknown field of tropical medicine. The institute was renamed as the Institute for Medical Research, or IMR, a year later. Initially, the focus of this research was on beriberi and malaria. Subsequently, it goes expanded into the causes, treatment, and prevention of a variety of tropical diseases such as cholera, smallpox, leprosy, tuberculosis, typhoid, filariasis, dengue, melioidosis, scrub typhus, and nutrient deficiencies. IMR was formerly located at Jalan Pahang, Kuala Lumpur, before moving to Shah Alam recently in a new research complex together with other research institutes under the Ministry of Health Malaysia. This specially designed building is enhanced and equipped with advanced and high-technology machines and instruments. It is now recognized to be a high-impact center in biomedical research at national and global level, with the presence of Biosafety Level 3, or BSL-3, Arthropod Containment Lab, or ACL, Good Laboratory Practice, GLP, and Biomedical Research Core Facility, BioRCF. Upon independence, IMR became the research arm for the Ministry of Health Malaysia, where research conducted has been aligned with the country's research priorities. In more recent times, research at the IMR has progressed in gathering in-depth knowledge of allergy and autoimmune diseases, primary immunodeficiency diseases, and the development of allergy test kits. The IMR has developed its expertise in nutritional biochemistry, where there is active involvement in preclinical studies on metabolic syndrome, diabetes, cardiovascular health, and endocrine-related diseases. The Institute's iodine test kit is used nationwide for monitoring purposes under the Iodine Deficiency Program. The dawn of the next millennium encountered many issues that were related to contaminants and pollutants in the environment and in the workplace, along with their impact on human health. Thus, in a forward-thinking manner, IMR conducted vulnerability assessment on impacts of climate change on health and health delivery. Cancer research at the IMR has vigorously looked at diagnostics, prevention and early detection, as well as identification of novel biomarkers and targeted therapy for precision medicine. For this, the Institute has been equipped with a specific pathogen-free or SPF animal facility and biobank. The Institute has established a unique interactive e-database called Global Information Hub on Integrative Medicine, or more commonly known as GlobenMed, which strives to become a referral source on traditional and complementary medicine, TNCM. In addition, herbal research activities are focused on the evaluation of herbal extracts under certified GLP conditions, assessing efficacy of herbal products using in vivo as well as in vitro systems, phytochemical analysis, as well as structure elucidation. The IMR has continued to provide in-depth research related to infectious diseases, especially during outbreaks, and it is the reference center for COVID-19, Zika, dengue, influenza, leptospirosis, melioidosis, and malaria. Epidemiology.
Allergy and Immunology Research Center, AIRC, founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading centre for immunological research and specialised diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Centre dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunisation. In 1930, this section was designated the Lymph Station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral centre for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories. Anti-aquaporin 4 antibodies, anti-N-methyl D-aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Programme for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
Autoimmune diseases, when the body attacks itself. Normal immune function is to protect the body from harmful pathogens, produce antibodies that target foreign antigens, and distinguish between self and non-self cells. In autoimmune conditions, recognition system malfunctions, healthy tissues mistakenly identified as threats, antibodies attack the body's own cells. What causes autoimmune diseases? Genetic factors, strong hereditary component with certain autoimmune conditions running in families. Specific gene variants increase susceptibility. Hormonal factor, women are 2 to 3 times more likely to develop autoimmune diseases than men, possibly due to hormonal differences. Environmental triggers, certain infections, exposure to chemicals, medications, and other environmental factors may trigger autoimmune responses in genetically susceptible individuals. Despite extensive research, the exact cause often remains unknown and is likely a complex interplay of multiple factors. Examples of autoimmune diseases. Rheumatoid arthritis attacks joint linings, causing painful inflammation and potential damage to joints, lungs and eyes. Type 1 diabetes. Immune system attacks insulin-producing cells in the pancreas, affecting blood glucose regulation. Multiple sclerosis damages the protective covering of nerve cells in the brain and spinal cord, disrupting communication signals. Common symptoms in autoimmune diseases. Persistent fatigue, overwhelming exhaustion that doesn't improve with rest. Joint and muscle pain, ranging from mild discomfort to severe, debilitating pain. Skin problems, rashes, sensitivity to sunlight, or changes in skin texture and appearance. Low-grade fever, persistent slight elevation in body temperature during disease activity. Swollen glands, digestive issues, abdominal pain, bloating, diarrhea or changes in bowel habits. Brain fog, difficulty concentrating, memory problems, and cognitive challenges. relapsing remitting pattern, symptoms often fluctuate between periods of flare and remission. However, the symptom profile differs across various autoimmune diseases and among individuals with the same condition. Diagnosing autoimmune diseases, gathering a thorough patient history, including symptoms, timeline, family history, and environmental exposures. Conducting a physical examination to identify signs of inflammation, rashes, joint swelling, or organ dysfunction. Performing blood tests for autoantibodies, inflammatory markers, organ function, and complete blood counts. Referring to specialists such as rheumatologists, endocrinologists, gastroenterologists, or other relevant experts based on the symptoms. Nevertheless, diagnosis can frequently be challenging and may require several years due to overlapping symptoms and the intermittent nature of numerous autoimmune conditions. Treatment and management. Goals: reduce inflammation, manage symptoms, prevent organ damage, induce and maintain remission, improve quality of life, minimize medication side effects. Medication: first line, corticosteroids, anti-inflammatories, immunosuppressant, biologics, targeted therapies, specific supplements, insulin, hormones, vitamins. Lifestyle modifications: anti-inflammatory diets may reduce symptom severity. Appropriate exercise maintains function and reduces pain. Stress management techniques help prevent flares. Sleep hygiene improves energy and immune regulation. Support systems: patient groups and mental health support can provide valuable emotional and practical assistance. Common misconceptions: autoimmune diseases are contagious. They're not. Symptoms are always visible, most are invisible. It's just in your head, symptoms are measurable, nothing helps, many treatments are effective. In conclusion, with proper knowledge, support, and healthcare, people with autoimmune diseases can sustain a good quality of life and manage their conditions effectively.
Pathological Institute of Kuala Lumpur was established in 1900 by the Resident General of British Malaya, Sir Frank Swettenham. Its aim was to promote the health status of the local population and to explore the great and unknown field of tropical medicine. The institute was renamed as the Institute for Medical Research, or IMR, a year later. Initially, the focus of this research was on beriberi and malaria. Subsequently, it goes expanded into the causes, treatment, and prevention of a variety of tropical diseases such as cholera, smallpox, leprosy, tuberculosis, typhoid, filariasis, dengue, melioidosis, scrub typhus, and nutrient deficiencies. IMR was formerly located at Jalan Pahang, Kuala Lumpur, before moving to Shah Alam recently in a new research complex together with other research institutes under the Ministry of Health Malaysia. This specially designed building is enhanced and equipped with advanced and high-technology machines and instruments. It is now recognized to be a high-impact center in biomedical research at national and global level, with the presence of Biosafety Level 3, or BSL-3, Arthropod Containment Lab, or ACL, Good Laboratory Practice, GLP, and Biomedical Research Core Facility, BioRCF. Upon independence, IMR became the research arm for the Ministry of Health Malaysia, where research conducted has been aligned with the country's research priorities. In more recent times, research at the IMR has progressed in gathering in-depth knowledge of allergy and autoimmune diseases, primary immunodeficiency diseases, and the development of allergy test kits. The IMR has developed its expertise in nutritional biochemistry, where there is active involvement in preclinical studies on metabolic syndrome, diabetes, cardiovascular health, and endocrine-related diseases. The Institute's iodine test kit is used nationwide for monitoring purposes under the Iodine Deficiency Program. The dawn of the next millennium encountered many issues that were related to contaminants and pollutants in the environment and in the workplace, along with their impact on human health. Thus, in a forward-thinking manner, IMR conducted vulnerability assessment on impacts of climate change on health and health delivery. Cancer research at the IMR has vigorously looked at diagnostics, prevention and early detection, as well as identification of novel biomarkers and targeted therapy for precision medicine. For this, the Institute has been equipped with a specific pathogen-free or SPF animal facility and biobank. The Institute has established a unique interactive e-database called Global Information Hub on Integrative Medicine, or more commonly known as GlobenMed, which strives to become a referral source on traditional and complementary medicine, T&CM. In addition, herbal research activities are focused on the evaluation of herbal extracts under certified GLP conditions, assessing efficacy of herbal products using in vivo as well as in vitro systems, phytochemical analysis, as well as structure elucidation. The IMR has continued to provide in-depth research related to infectious diseases, especially during outbreaks, and it is the reference center for COVID-19, Zika, dengue, influenza, leptospirosis, melioidosis, and malaria. Epidemiology.
Allergy and Immunology Research Center, AIRC, founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading center for immunological research and specialized diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Center dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunization. In 1930, this section was designated the Lymph Station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral centre for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI-spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories. Anti-aquaporin 4 antibodies, anti-N-methyl D-aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's, and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Program for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
Autoimmune diseases, when the body attacks itself. Normal immune function is to protect the body from harmful pathogens, produce antibodies that target foreign antigens, and distinguish between self and non-self cells. In autoimmune conditions, recognition system malfunctions, healthy tissues mistakenly identified as threats, antibodies attack the body's own cells. What causes autoimmune diseases? Genetic factors, strong hereditary component with certain autoimmune conditions running in families. Specific gene variants increase susceptibility. Hormonal factor, women are 2 to 3 times more likely to develop autoimmune diseases than men, possibly due to hormonal differences. Environmental triggers, certain infections, exposure to chemicals, medications, and other environmental factors may trigger autoimmune responses in genetically susceptible individuals. Despite extensive research, the exact cause often remains unknown and is likely a complex interplay of multiple factors. Examples of autoimmune diseases. Rheumatoid arthritis attacks joint linings, causing painful inflammation and potential damage to joints, lungs, and eyes. Type 1 diabetes. Immune system attacks insulin-producing cells in the pancreas, affecting blood glucose regulation. Multiple sclerosis damages the protective covering of nerve cells in the brain and spinal cord, disrupting communication signals. Common symptoms in autoimmune diseases. Persistent fatigue, overwhelming exhaustion that doesn't improve with rest. Joint and muscle pain, ranging from mild discomfort to severe, debilitating pain. Skin problems, rashes, sensitivity to sunlight, or changes in skin texture and appearance. Low-grade fever, persistent slight elevation in body temperature during disease activity. Swollen glands, digestive issues, abdominal pain, bloating, diarrhea, or changes in bowel habits. Brain fog, difficulty concentrating, memory problems, and cognitive challenges. Relapsing remitting pattern, symptoms often fluctuate between periods of flare and remission. However, the symptom profile differs across various autoimmune diseases and among individuals with the same condition. Diagnosing autoimmune diseases. Gathering a thorough patient history, including symptoms, timeline, family history, and environmental exposures. Conducting a physical examination to identify signs of inflammation, rashes, joint swelling, or organ dysfunction. Performing blood tests for autoantibodies, inflammatory markers, organ function, and complete blood counts. Referring to specialists such as rheumatologists, endocrinologists, gastroenterologists, or other relevant experts based on the symptoms. Nevertheless, diagnosis can frequently be challenging and may require several years due to overlapping symptoms and the intermittent nature of numerous autoimmune conditions. Treatment and management. Goals: reduce inflammation, manage symptoms, prevent organ damage, induce and maintain remission, improve quality of life, minimize medication side effects. Medication: first line, corticosteroids, anti-inflammatories, immunosuppressant, biologics, targeted therapies, specific supplements, insulin, hormones, vitamins. Lifestyle modifications: anti-inflammatory diets may reduce symptom severity. Appropriate exercise maintains function and reduces pain. Stress management techniques help prevent flares. Sleep hygiene improves energy and immune regulation. Support systems. Patient groups and mental health support can provide valuable emotional and practical assistance. Common misconceptions. Autoimmune diseases are contagious. They're not. Symptoms are always visible. Most are invisible. It's just in your head. Symptoms are measurable. Nothing helps. Many treatments are effective. In conclusion, with proper knowledge, support, and healthcare, people with autoimmune diseases can sustain a good quality of life and manage their conditions effectively.
The Pathological Institute of Kuala Lumpur was established in 1900 by the Resident General of British Malaya, Sir Frank Swettenham. Its aim was to promote the health status of the local population and to explore the great and unknown field of tropical medicine. The institute was renamed as the Institute for Medical Research, or IMR, a year later. Initially, the focus of this research was on beriberi and malaria. Subsequently, it goes expanded into the causes, treatment, and prevention of a variety of tropical diseases such as cholera, smallpox, leprosy, tuberculosis, typhoid, filariasis, dengue, melioidosis, scrub typhus, and nutrient deficiencies. IMR was formerly located at Jalan Pahang, Kuala Lumpur, before moving to Shah Alam recently in a new research complex together with other research institutes under the Ministry of Health Malaysia. This specially designed building is enhanced and equipped with advanced and high-technology machines and instruments. It is now recognized to be a high-impact center in biomedical research at national and global level, with the presence of Biosafety Level 3, or BSL-3, Arthropod Containment Lab, or ACL, Good Laboratory Practice, GLP, and Biomedical Research Core Facility, BioRCF. Upon independence, IMR became the research arm for the Ministry of Health Malaysia, where research conducted has been aligned with the country's research priorities. In more recent times, research at the IMR has progressed in gathering in-depth knowledge of allergy and autoimmune diseases, primary immunodeficiency diseases, and the development of allergy test kits. The IMR has developed its expertise in nutritional biochemistry, where there is active involvement in preclinical studies on metabolic syndrome, diabetes, cardiovascular health, and endocrine-related diseases. The Institute's iodine test kit is used nationwide for monitoring purposes under the Iodine Deficiency Program. The dawn of the next millennium encountered many issues that were related to contaminants and pollutants in the environment and in the workplace, along with their impact on human health. Thus, in a forward-thinking manner, IMR conducted vulnerability assessment on impacts of climate change on health and health delivery. Cancer research at the IMR has vigorously looked at diagnostics, prevention and early detection, as well as identification of novel biomarkers and targeted therapy for precision medicine. For this, the Institute has been equipped with a specific pathogen-free or SPF animal facility and biobank. The Institute has established a unique interactive e-database called Global Information Hub on Integrative Medicine, or more commonly known as GlobenMed, which strives to become a referral source on traditional and complementary medicine, T&CM. In addition, herbal research activities are focused on the evaluation of herbal extracts under certified GLP conditions, assessing efficacy of herbal products using in vivo as well as in vitro systems, phytochemical analysis, as well as structure elucidation. The IMR has continued to provide in-depth research related to infectious diseases, especially during outbreaks, and it is the reference center for COVID-19, Zika, dengue, influenza, leptospirosis, melioidosis, and malaria. Epidemiology.
Allergy and Immunology Research Center, AIRC, founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading center for immunological research and specialized diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Center dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunization. In 1930, this section was designated the Lymph Station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral centre for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories. Anti-aquaporin 4 antibodies, anti-N-methyl D aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's, and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Program for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
Autoimmune diseases, when the body attacks itself. Normal immune function is to protect the body from harmful pathogens, produce antibodies that target foreign antigens, and distinguish between self and non-self cells. In autoimmune conditions, recognition system malfunctions, healthy tissues mistakenly identified as threats, antibodies attack the body's own cells. What causes autoimmune diseases? Genetic factors, strong hereditary component with certain autoimmune conditions running in families. Specific gene variants increase susceptibility. Hormonal factor, women are 2 to 3 times more likely to develop autoimmune diseases than men, possibly due to hormonal differences. Environmental triggers, certain infections, exposure to chemicals, medications, and other environmental factors may trigger autoimmune responses in genetically susceptible individuals. Despite extensive research, the exact cause often remains unknown and is likely a complex interplay of multiple factors. Examples of autoimmune diseases. Rheumatoid arthritis attacks joint linings, causing painful inflammation and potential damage to joints, lungs, and eyes. Type 1 diabetes. Immune system attacks insulin-producing cells in the pancreas, affecting blood glucose regulation. Multiple sclerosis damages the protective covering of nerve cells in the brain and spinal cord, disrupting communication signals. Common symptoms in autoimmune diseases. Persistent fatigue, overwhelming exhaustion that doesn't improve with rest. Joint and muscle pain, ranging from mild discomfort to severe, debilitating pain. Skin problems, rashes, sensitivity to sunlight, or changes in skin texture and appearance. Low-grade fever, persistent slight elevation in body temperature during disease activity. Swollen glands, digestive issues, abdominal pain, bloating, diarrhea, or changes in bowel habits. Brain fog, difficulty concentrating, memory problems, and cognitive challenges. Relapsing remitting pattern, symptoms often fluctuate between periods of flare and remission. However, the symptom profile differs across various autoimmune diseases and among individuals with the same condition. Diagnosing autoimmune diseases. Gathering a thorough patient history, including symptoms, timeline, family history, and environmental exposures. Conducting a physical examination to identify signs of inflammation, rashes, joint swelling, or organ dysfunction. Performing blood tests for autoantibodies, inflammatory markers, organ function, and complete blood counts. Referring to specialists such as rheumatologists, endocrinologists, gastroenterologists, or other relevant experts based on the symptoms. Nevertheless, diagnosis can frequently be challenging and may require several years due to overlapping symptoms and the intermittent nature of numerous autoimmune conditions. Treatment and management. Goals: reduce inflammation, manage symptoms, prevent organ damage, induce and maintain remission, improve quality of life, minimize medication side effects. Medication: first line, corticosteroids, anti-inflammatories, immunosuppressant, biologics, targeted therapies, specific supplements, insulin, hormones, vitamins. Lifestyle modifications. Anti-inflammatory diets may reduce symptom severity. Appropriate exercise maintains function and reduces pain. Stress management techniques help prevent flares. Sleep hygiene improves energy and immune regulation. Support systems. Patient groups and mental health support can provide valuable emotional and practical assistance. Common misconceptions. Autoimmune diseases are contagious. They're not. Symptoms are always visible, most are invisible. It's just in your head, symptoms are measurable, nothing helps, many treatments are effective. In conclusion, with proper knowledge, support, and healthcare, people with autoimmune diseases can sustain a good quality of life and manage their conditions effectively.
The Pathological Institute of Kuala Lumpur was established in 1900 by the Resident General of British Malaya, Sir Frank Swettenham. Its aim was to promote the health status of the local population and to explore the great and unknown field of tropical medicine. The institute was renamed as the Institute for Medical Research, or IMR, a year later. Initially, the focus of this research was on beriberi and malaria. Subsequently, it goes expanded into the causes, treatment, and prevention of a variety of tropical diseases such as cholera, smallpox, leprosy, tuberculosis, typhoid, filariasis, dengue, melioidosis, scrub typhus, and nutrient deficiencies. IMR was formerly located at Jalan Pahang, Kuala Lumpur, before moving to Sesha Alam recently in a new research complex together with other research institutes under the Ministry of Health Malaysia. This specially designed building is enhanced and equipped with advanced and high-technology machines and instruments. It is now recognized to be a high-impact center in biomedical research at national and global level, with the presence of Biosafety Level 3, or BSL-3, Arthropod Containment Lab, or ACL, Good Laboratory Practice, GLP, and Biomedical Research Core Facility, BioRCF. Upon independence, IMR became the research arm for the Ministry of Health Malaysia, where research conducted has been aligned with the country's research priorities. In more recent times, research at the IMR has progressed in gathering in-depth knowledge of allergy and autoimmune diseases, primary immunodeficiency diseases, and the development of allergy test kits. The IMR has developed its expertise in nutritional biochemistry, where there is active involvement in preclinical studies on metabolic syndrome, diabetes, cardiovascular health, and endocrine-related diseases. The Institute's iodine test kit is used nationwide for monitoring purposes under the Iodine Deficiency Program. The dawn of the next millennium encountered many issues that were related to contaminants and pollutants in the environment and in the workplace, along with their impact on human health. Thus, in a forward-thinking manner, IMR conducted vulnerability assessment on impacts of climate change on health and health delivery. Cancer research at the IMR has vigorously looked at diagnostics, prevention and early detection, as well as identification of novel biomarkers and targeted therapy for precision medicine. For this, the Institute has been equipped with a specific pathogen-free or SPF animal facility and biobank. The Institute has established a unique interactive e-database called Global Information Hub on Integrative Medicine, or more commonly known as GlobenMed, which strives to become a referral source on traditional and complementary medicine, T&CM. In addition, herbal research activities are focused on the evaluation of herbal extracts under certified GLP conditions, assessing efficacy of herbal products using in vivo as well as in vitro systems, phytochemical analysis, as well as structure elucidation. The IMR has continued to provide in-depth research related to infectious diseases, especially during outbreaks, and it is the reference center for COVID-19, Zika, dengue, influenza, leptospirosis, melioidosis, and malaria. Epidemiology.
Allergy and Immunology Research Center, AIRC, founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading center for immunological research and specialized diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Center dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunization. In 1930, this section was designated the Lymph Station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral centre for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI-spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories. Anti-aquaporin 4 antibodies, anti-N-methyl D aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's, and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Programme for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
Autoimmune diseases, when the body attacks itself. Normal.
3. Ladies and gentlemen, we're about to start our next session, so please be seated. Distinguished speakers, participants, ladies and gentlemen, welcome again to the National Autoimmune Day 2025. I hope everyone had a wonderful lunch break and are enjoying yourself at the seminar so far. We are now going to continue our afternoon session with a talk entitled Diagnostic Updates for Myositis, which will be delivered by Mr. Lee Xing Leung from Autoimmune. A brief introduction about Mr. Xing. He graduated from the International Medical University with a Bachelor of Medical Sciences and is now the Regional Sales Manager for Malaysia and Indonesia for Autoimmune, Southeast Asia. He has an industry experience of combined 12 years in multinational and local companies. Without further ado, Mr. Xing, the floor is yours.
Okay, good afternoon, everyone. So I'll try to make this as short and sweet as possible. So semua pun tak ada mengantuk tak sangat lah. So I hope everyone will bear with me, and I will just give a bit of updates. I think most people are familiar with over here was kawan-kawan. I think most of you are familiar with our tests, but there is a few new products and a few new technologies that are available recently. So I will go through the slides, and then I will spend just a bit more time over there lah. So if you see some repeated points, I will just mention it on passing, and then hopefully everybody remembers and reinforce. Like Dr. Ane says, repetition is a mother of teaching style that will help you get into your brain and also into your heart lah, kan? So let's start. So like I said, my name is Xing. I'm from now representing Autoimmune from Malaysia and Indonesia markets, and I will just do a bit of introduction of the company. So of course, Autoimmune is a German company. It's based in Lübeck. So it started in 1987 as a research base. So a professor, it was more of a private-public collaboration. The professor the team that did the products actually eventually made it commercialized, and so there's 16 subsidiary branches globally, right? Also, it's been growing quite well. Of course, with the technology and the support that we have from the market, we have actually been able to actually be one of the leaders in autoimmune, allergy, and infectious diagnostics. So just a bit of summary, you can see here, there's a long history of innovation. Started all the way by 1979 with research, and then what we really are like key leaders in the immunofluorescence techniques, right, cellular base, but we also have, of course, everything up to ELISA, molecular, and automation also. So as you can see, we are a global company. Right now, we are actually going through a bit of a change because we have been acquired by Revity. So we are part of the Revity brand, but we are present in nearly every major country, either through direct office representation or like for a Malaysia distributorship. For Malaysia and Indonesia, we work with distributors like Chemofarm. So over here is just a few pictures of the offices and the manufacturing plants that you can see. Lübeck. I myself personally have not had the chance to go. I think Dr. Masita pernah satu kali kan? Dr. Masita. So, and also some of our leading players in the market, like for example, LabLink, who have been using our kits for very long, have actually been able to go there and have direct communication and also learning of how the kits are developed, what can be done better lah for the region. So this is our Singapore office. So you can see this was taken when it was very young lah. So over here, let me see the laser. Over here is all, this was the space where we actually have our demo lab. So for those who have had the chance to come and join us for our Autoimmune Academy, this is where we usually do our trainings, our meetings, to update on the latest techniques and latest technologies. So every year, typically we have it once a year, and we hope to actually welcome more of you there. So over here, usually we will invite guest speakers and our own team applications will actually do. So this year we had the privilege of inviting two neurologists from UKM, actually, Prof. Tan, to share a bit about autoimmune neurology for the region. So usually all the around the Indonesia, the regional specialists or regional lab techs will actually join us so that we can actually share information, do a bit of updates with each other, both on the lab side and also the clinical side. So that I mentioned, these are the diagnostics that we typically offer. Of course, we major in autoimmune diagnostics, but we do have niche products for infection, allergy, antigen detection, for example, in molecular side also, like ApoE, one of the Alzheimer genetic molecule that we actually are coming up. And we have automation solutions ranging from all the immunofluorescence, ELISA, immunoblot, and also real-time PCR. Now, these are some of the snapshot of the automation solutions that we have. Some of it might be familiar, some of it not, depending on the region and country. I think for Dr. Asrul and his team, they are very familiar with the immunofluorescence automation. Right? One thing that we are bringing in, we are the leader in this country for immunofluorescence automation. But we also have blot processors, which help ease, of course, the manual processing. So I'll just show you the machines that we actually offer and how it looks like later. So this is just a quick one. I'm going to do a very quick run through on the autoimmune myopathies, inflammatory myopathies in terms of the markers that we have and the products. And you see like what options you have, and maybe you can consider bringing it to your own clinics or your own labs. So this slide was already prepared by my marketing colleague, Esther Lee. Unfortunately, she's not able to join today, but these slides are quite helpfully made by her. So I won't spend too much time, but these are the general classifications of myositis that we actually have heard. Right? You have your polymyositis, your dermatomyositis, your inclusion body, and your immune-mediated necrotizing. So one thing is important is we need to know these different types because they present differently, and also treatment-wise and progression-wise, we want to manage it quite properly, as the doctors here have actually mentioned. So I will focus, in terms of diagnostic tools, there are many, of course. You started a long time ago with, of course, you got a clinical examination, then you have your blood tests, your enzymatic tests, right? And now finally in this era, we actually have specific myositis antibodies, which I will be talking about. So as you can see, there are many, banyak, right? And one of the key things about myositis markers is that you know that it's, in terms of its prevalence, one of the key things is each of them that wouldn't exceed 50% in terms of prevalence. So there's no one, right? There's many, and as we go on and on in our research, we go find many more. And this is a good thing because we actually can now be able to identify without doing biopsies, right? Just by a simple serum detection, you can actually do a immunological testing for it. Okay, so just generally, there are two classes of antibodies. One we call myositis-specific antibodies, and one is myositis-associated. But these are still areas of research. So like the first talk, Dr. Asrul pun kata, what used to be thought as myositis-specific like can actually become more associated as more research is done. For example, what was it yang pertama tu? CN1A, yeah. When I started, I think talking about this was nearly more than 3 years ago, or specific. But after dah 3-5 tahun ni, it become more associated as we find it in more and more other diseases. Okay, so now, in how to diagnose. Okay, Autoimmune is actually a leader in immunofluorescence techniques, and we will still say there is a place for this, but the challenge definitely exists when it comes to myositis, right? Because, as we know, there are issues there's no clear pattern agreement, right, for certain markers like HMGCR, MDA, CN1A. None that we can find yet. Some MSA cannot be observed at all, right, for example, ARS. But there are some advantages of still maintaining because it's a very common screening tool, it's cheap, right? And you have certain patterns, maybe they're cytoplasmic in nature, that can be associated to plausible cases. But you still have to know that it overlaps with other things. For example, Ro52 may be there, dsDNA may be also there, low grade may be there. So what can we do in this case? Well, we do have solution, right? For example, we have at least some guidelines that say there is some utility in terms of the 2009 statement. Myositis can be detected in HEP2 immunofluorescence, but the sensitivity, of course, is not as high as your classical SLE, which is your ANA patterns. You can get very high sensitivity. But here, we have to just take note, it's 61. So there might be something fluorescing, but we need to further up with a step 2 for confirmation. So this is why we need a confirmation, because as you can see, Somadu, the IFT pattern is the cytoplasmic, all right? Most of it is cytoplasmic. So from your antibody JO1, PL, EJ, OJ, KS, Somadu, a lot of it is cytoplasmic speckle. And as we know, many times it might be not reported because it's cytoplasmic, so NA negative. So then you miss it out. But and over here, yeah, it's the classical. You can see MDA5, especially for our region, with the high Asian prevalence of MDA5, it can be just negative, which could be a problem. So what we want to do is we just want to increase awareness that if something is clinical there, ultimately diagnosis cannot be just a single lab test. It has to be clinical, working together with the laboratory findings, imaging findings, and then finding out the most accurate diagnostic and also treatment plan. So over here you can just see these are the nice pictures that hopefully we can find, right? And you can see in your lab. Over here you draw one. These are the pictures that might come out. But of course, the challenge is identifying it, and a technician has to be quite used to it, doing a lot of it to actually spot these. And sometimes they are actually not in the, we would call it the competent stage. It's more like advanced stage. So it requires training. So there is definitely a challenge. And then if you can see here, it's dim. So MDA5, this could be easily called ANA negative, and they will be right? But the disease is still there. So what can we do? At least in terms of technology-wise, Autoimmune has made some technologies available. For example, right, we have this all-in-one automation that's now available in the market. We are bringing into certain labs to do evaluations, and probably will be available soon. And Dr. Asro's lab is going to have a smaller version of this. So this is fully automated. You letak saja sample dalam, and then it runs all the way from processing to imaging and reporting. But this is a high investment. I definitely understand why. I would not say semua mesti dapat. Right? It will be strategically located, strategically proposed to certain centers, and then hopefully by that at least it's available to be samples can be referred there, patient can be referred there. All right. So together with this machine, we also have AI assisted image recognition software called EuroLab Office 4 and Classifier, where all the negative and positives will be able to screen in a rapid manner, and then a pathologist need to only review and confirm the patterns and reporting in terms of its titer, its pattern, and certain differentiation, and also what tests to follow up on. So with this, we ease the burden of at least of the screening, the high workload. Yang dulu perlu a lot of effort to the machine, and then we, of course, as human beings, still of course have our role to consult each other, doctors, multidisciplinary MDT, multidisciplinary teams, and also to provide the best care that we can for the patients. Right? So this is what is available going forward. So many is digital, so there's not much like physical zooming. So you can even see there's no manual microscopy really required, but all can be done digitally. And this is just just doing a quick review of what can be reported. So for example, in the classifier technology, you can actually identify up to 9 fluorescence ANA patterns. So homogeneous, speckled, dense, fine speckled, nuclear dots, centromeres, nuclear membranes, AMA, and cytoplasmic in general. So down to the AC, apa tu tak boleh lah, but at least it can give you a cytoplasmic classification in general, that for further investigation and also specific testing. So this is the ANA. And this machine, of course, is not just for ANA. I highlight this because it's relevant for myositis. It can also be used to identify neurology cells, tissue, liver cells and tissue. Many other immunofluorescence based tests can be on this platform. Okay, so there you go. the one that cannot be identified can actually still be done with initial testing. Then the next part, of course, I'm going to bring now is to my Euroline, the blood line tests which are available in Malaysia and used for myositis testing. They are available in Selayang and many other places. So this is just general flow, but what we would highly recommend is between all of them, what is closely, I guess, represented is this between ANA and systemic sclerosis, one of the disease which is quite similar in terms of clinical manifestation, initially at least. What we do is a two-step method. ANA first, then with a multiplex system like our blots to be done. So don't worry about this. This is just a bit about why we do need to pay a bit more attention, and there is more interest in this these days is because there is particularly the interstitial lung disease complication that we see from the disease, and also underlying malignancy that can come up after detection of these antibodies, which I think all speakers have already repeatedly mentioned. So I won't spend too much time about ILD, right? This one also you can just see there are, as mentioned, right, these anti-synthetase or these particular ones can have been shown to be highly correlated with ILD, so we won't spend too much time here. This one, you can see just a bit of highlight. So besides TIF1, which is the light blue, this teal, there are other markers which you can see in other types of diseases. I'm not sure whether you can see very clearly, but besides lung cancer, you can also see other types of cancer, breast cancer, with myositis-specific antigens. There is even like, I think these are blood hematological cancers, right? We've actually have seen quite a few of these markers being correlated. So many kinds of cancers do show, do have these markers present before the cancers are actually diagnosed. So when the cancers are there, they correlate by, hey, this patient has a history of these appearing before the cancers are actually detected. So this is the clinical, how our test strip will look like, but this is of course color-coded. It doesn't look actually like this. Just for ease of classification, these markers you can see represent the major class of autoimmune myopathies. So IMNN, in CN1A over here, HMGCR. So this would be, I think, the most prolific marker that's available. So it's 18 markers available with MDA in Malaysia right now. It's called the -8. -8 profile. So you will see this being offered in line. So what is available in Malaysia right now is these two. So the top one is the CN1A plus HMGCR. That's the most comprehensive with MDA. Selayang, if I'm not mistaken, is actually the -4. So it's only missing HMGCR and CN1A. So this would actually be a good one, especially if, let's say, most of the patients are pediatrics or centers, or you don't really see that. But I think going forward with more and more detection and more cases suspected of having HMGC and CN1A, this is something that we are working with ChemoPharm to actually provide Selayang and the country. In the private center, most of your major lab partners would have this, so it's easily found, and they have a turnover time of within 3 to 5 days or a week. So that would be available to Malaysian patients. And it's quite interesting that actually in Malaysia, in terms of our access and exposure, it's much higher, quite one of the highest in the region, I would say. Let's say compared to our neighbors in Indonesia, unfortunately, the awareness is not there. So I'm very happy to hear that there are experts coming back who are interested to work together, and opportunities like this where we gather together. It's quite special actually. In other countries, sometimes they don't have the resource or the time or maybe political will, some people say, to actually do it, but we do, and I hope to see us continuing doing this so that our neighbors, our population, our friends and our families will be able to get the best care and treatment possible. So besides these panel, there is one additional latest panel that we have, the 20 antigen one, which is coming up. So what this does, it adds in HAR, KS and ZO, and these are actually anti-synthetase molecules that are linked to ILD. That's why I think the next group of doctors that we want to actually engage closely with is maybe the chest physicians, or maybe even the ENTs, right, who actually do see patients who may be coming in with a bit of mild symptoms, just starting respiratory issues. These would be actually something that we want to offer, maybe in a research kat AIMA dulu, buat satu project dulu. Then if we find out that there is high prevalence, reasonable prevalence, we can actually start making proposals to certain centers or maybe HKL or IPR to actually make it a part of their protocol, the screening. So this is not registered yet, but I can just tell you that this is actually available and something that we might want to do research with. Okay. So in terms of reading those strips that we saw, we of course have these other machines and also systems available. So Euroline Scan is the scanning software that makes the interpretation easy. So tak perlu tengok like subjective, like whether it's dark, what. These are actually all calibrated to give you classifications, right? So it's from anyway from negative to 4 classifications: negative, borderline, positive, and strongly positive. So everything can be done on automation machine. Of course, kalau sample kurang, you can start manually first, and then you can do it through a manual scanner. But once you go to, of course, maybe like center like IMR sudah jadi referral Selayang, you can have a full automation with Euroblot 1. So everything can be done there. Right now, Selayang has a semi-auto. Maybe in the future, we're looking to upgrade once we're dah jadi memang with a center that has more and more need. We will actually put out a full automation where you can process, and the machine itself can scan straight away and push the results right to the system and also to LIS lah. So hopefully once the LIS system is solved, we can straight away do integration somewhere. Okay, so that is it basically. I open the questions, quick one, and then I can pass the time to our final presenter.
Are there any questions from the audience for Mr. Shing? Right.
Thank you, Shing. Just now I can see that you have 18 just now, lepas tu 20 kan?
Yeah.
So the 21, why the HMGCR not there?
So the trade-off is yang ni, they have taken out the HMGCR and CM1A. I think it's in terms of targeting. That's why when we say this, it's more for more lung suspicion. So kalau tak, then it will be more costly. Usually costing. So I think with a market research, certain countries, for example, China, Hong Kong, Taiwan, the asiatic East Asian countries, banyak actually have ILD complication from myositis suspicion. So much so that they actually have programs, national insurance program or national screening programs that have a budget to actually do this testing. So I think it's a response to the market lah. So the HMGCR CNO satu sana, and then kalau the patient coming in with like suspected chest already, they straight away go for this one. So it's a way of like managing cost benefit lah. Yeah.
Any more questions from the floor? To our online viewers on YouTube Live, you can ask or post your questions through the link given earlier today, and those questions will be addressed by our speakers through email. If there are no questions, thank you, Mr. Shing, for the very informative presentation. Now I would like to ask Mr. Shing to remain on the stage and invite Dr. Masita to present a certificate of appreciation to our speaker. Mr. Shing for the presentation and Dr. Masita. Ladies and gentlemen, moving on with the last session for today's event. This next talk is entitled From Bench to Bedside, the Updates in Myositis Research and Challenges, which will be delivered by Dr. Tu Chun Lai from the Immunogenetics Unit, ARIC, IMR. A brief introduction on Dr. Tu. She is the head of the Immunogenetic Unit at the Allergy and Immunology Research Center, IMR. She obtained her PhD in medicine from Karolinska Institute, Sweden, and a degree in biomedicine from University Putra, Malaysia. With over 20 years of experience, she specializes in immunogenetics and rheumatology, bridging clinical and translational research. Her work spans inflammatory arthritis, transplantation immunology, and infectious diseases such as dengue. She leads Malaysia's participation in the epidemiological investigation of rheumatoid arthritis ERA with Karolinska Institute and has coordinated one of Southeast Asia's largest RE cohorts. Without further ado, Dr. Tu, the floor is yours.
Okay. Thank you, Nani. Maybe we don't dim the light first because now is only 2:40. Don't dim it first. We can't start first because if I finish quite early, the food is not ready anyway. So we don't want to waste the food also. So I have to buy some time according to my colleagues here. I have to buy some time, try to delay it for an hour. So we try to interact with all of you. So what I'm going to ask a few questions to the audience. Please, may I know, first of all, of course, I thanks to my boss, Dr. Mashita, and also the Secretariat for inviting me for this talk. When I get this topic, I was a little bit shocked. Why? Because I have been working with the joint for the past 20 years. Now I have to work with the muscle. I say, okay, never mind. There are some terminology which is the same. Autoimmune diseases is the same, okay. And then inflammation is the same, okay. Symmetrical, okay, that is quite similar. But then from muscle, I move from joint to the muscle. So I will try my best to share with you, not so much on the topic itself because I am not a medical doctor background. So not so much on the clinical sides of myositis, but I will talk to you what my experience with research, and I try to use my knowledge to put up the slides for you so that at the end of the day you will find these sessions benefit. First of all, may I know how many of you are medical doctor in this room? Tinggi-tinggi lah. Okay. How many are non-medical? Okay. There's quite a lot of non-medical. Okay, how many of you have engaged with myositis except the first line? The ones that from second line to the end, how many of you have actually involved directly or indirectly in myositis? Anyone? 1, 2, 3, 4. Adalah. So, I tak boleh kelentong lah. Kalau saya salah, tolong betulkan eh. Okay. Now, we start. So, for the first sessions, I'm going to show you on what happens or what have been published in Malaysia. And then I try to put all these informations into the gaps. Again, a lot of topics. Being the last one can be the bless, can be a blessing, can be a cursing. Blessing is all my colleagues have covered the topic, so it will make my life a little bit easier. But the cursing is what am I going to talk for the next 1 hour? So that will be a challenge for me. So with that, I try my best. Now we can dim the light. I try to make it very colorful because this is a last presentation, but I don't think so with the light quality here, we can't do anything about it. So just bear in mind that this is actually a light blue background, not a white, okay? So we have talked about idiopathic inflammatory myopathy. Is a collective term for autoimmune diseases, which is characterized by chronic inflammations of the muscles, and is a very progressive weakness to the patients and will cause disability in long run. So basically, these are the subtypes. I just list down 5 of the subtypes. There are many, many more, depends. If even from the morning sessions, we know that the myositis even been defined according to what kind of antibody been detected in this myositis conditions. So then in Malaysia, actually, we have a guideline being published in 2023 according to WHO coding. Actually, if you can see here, dermatomyositis or polymyositis has been classified as rare diseases. So this is a disadvantage when come to a researcher. When come to research, we always have difficulty to justify something rare. They will say, the funder will say, if this is rare, then this is very small populations will get involved in these diseases. So what is the significance compared to the lifestyle diseases, for example, lung cancers, those smoking, alcohol, or fatty liver, or anything else. So we are in the disadvantage positions in getting the fund. But not to worry, 2023, because WHO have raised the awareness of rare diseases. So this is how we can justify. In fact, in Malaysia, RMK 13 next year, going to start 2026 up to 2030. There will be a special allocations for rare diseases where we can come in and ask for funding and tell them that this is a national priority research area. So you will see that soon. So if you see this 3 dot, this is like a location, right? Only 3 dot. So what I'm going to tell you is, this is the selected Malaysian myositis bibliography that I can search from. I go PubMed, I go Cochrane, I go Embase and search for it. Of course, there is thousands, then there are many thousands, scrutinized to 397. When I further scrutinize them, those related to today's topic, which is autoimmune related myositis, is just this few. For the past 30 years, we only have the 7 publications which is most related to our topics today. And these are the papers. I'm going to bring you through one by one. It won't take you long because I have summarized them. Because it is important for us to know what has been published, what has been studied, what else has been covered by this group of researchers. Is there any author of these publications here? That would be amazing if he or she can share with us the experience. So what I'm going to do now is, the first part of my presentation will be to summarize the key Malaysia IMM studies from 1995 to 2021, highlight the trend in malignancy association, especially for the NPC, nasopharyngeal carcinoma, and identify the diagnostic gaps and research need for the local context. I think my colleagues, especially Dr. Tara, she have shared with us a lot of the service gaps that has been identified in the clinical, from the bedside. So we're going to translate it into the bench. So this is the first review from HKL in 1995. They are looking at dermatomyositis, data source from 1989 to 1993. So looking at the time frame they have captured the cases retrospectively, this is only 8 dermatomyositis cases has been captured, and 75% of them are female. If you look at here, 87.5% are Chinese, with only 1 Malay patients. Their mean age is 41 to 60, and only 1 juvenile cases. So what is their clinical and malignancy finding? Even with 8 cases, this is what they say. All the patients are characterized by rashes or proximal weaknesses, and with elevated enzyme, which is CK and LDH. and almost 50% of them having a positive dermatomyositis skin biopsy. 37.5 of them are having malignancy, mainly in NPC, mainly are NPC, nasopharyngeal, and all of them under 50 years old. This is very important because I'm going to compare with others' publication later on. Unfortunately, these patients, they are responded to the steroid, which is corticosteroid. Unfortunately, those with malignancy, they cannot tolerate or respond well to steroid. Moving on is what kind of challenges they are facing and what do the author recommend back then, about 30 years ago. This is what they have says. We always suffer from small sample size. If we are working with retrospective samples, it's always incomplete data or incomplete lab assessment, for examples. So they are incomplete electromyography or also the muscle biopsy. And patient lost to follow up. Back then, 30 years ago, we have unclear malignancy screening protocol, and then therefore they have recommended to advocate the regular MPC screening in this myositis patient. Next, again, is HKL, leading by HKL also. They are looking for those dermatomyositis with cancer, and they call it paraneoplastic dermatomyositis. Oops. Sekejap Tidak jauh sikit. Okay. So, looking at here, they have almost 10 years data, 38 patients in total. Again, we are seeing the ethnicity is dominating by the Chinese, 55.6 of them. 33.3% are Malay, and then followed by 5.6 of Indian, and most of them are Chinese male with mean age of 53.8. When we see the cohort of dominant of Chinese, dominant of male, we start to worry about NPC because they are very strongly related, strongly associated. So true enough, 47.4 of them are associated with cancer and predominantly NPC in the Chinese patients. So some of the findings from this paper shows that 61.1% of the cancer reported is actually NPC, and the clinical or the clinical features that are presented is photo-distributed rashes and proximal weakness. So the group says that the ENT evaluations is very crucial because it's always come with NPC. But then they also found that the tumor marker that they have back then is ineffective for initial screening. The tumor marker that they have investigated is CA125, PSA, CA, CA199. So tumor marker is not something that they can rely on. So come to the treatment. For this, the author suggests that the clinicians feel that to treat the underlying cancer is the key for dermatomyositis resolution. Perhaps that is also reflecting what Dr. Tara have shared with us this morning. We don't see myositis, that many myositis patients in our clinical setting. Perhaps they has been treated in elsewhere, which is could be the oncology, could be the ENT, could be some other disciplinary, but they didn't make it to rheumato. So maybe that is something that we have to start to think of. If we want to start a research, we have to call this team to actually try to understand what kind of scenario we have in Malaysia clinical setting. And until now, there are limited. This is a single-centered study with incomplete data, with limited antibody testing. And even though they suspected of NPC, EBV was not tested. So 33.3 of them have been defaulted from this study that have actually hindered the outcome assessment. So moving on from HKL, now we move to Sarawak. 2012, we have Dr. Teh Chin Lei. She is a very active clinician, rheumatologist, who like research so much. And thanks to her, quite a number of autoimmune diseases papers has been published by her. That is where we get our references. So in 2012, the Sarawak teams has been investigate in polymyositis and dermatomyositis in Sarawak. So they are having about 12 patients with a mean age of 57.8, mostly Chinese female. Now it's Chinese female. HKL Chinese male, now it's Chinese female. So being someone who worked so much in genetic, I will start to think, is this a genetic associated diseases? So we will start to think about that. So in this cohort, they have more dermatomyositis patients as compared to the polymyositis patients with a ratio of 3:1. And if this morning we hear from Dr. Tara again, there is a delay in diagnosis from 9 to 14 months. Back then, in this paper, they say from onset to diagnosis, it took them 3.67 months. So clearly there is a delay in diagnosis. So this is the finding and malignancy link that they have found. All patients with proximal myopathy. The dermatomyositis patients are commonly presented with all these features, which you have seen these pictures from Dr. Ani's slides. So we will repeat it again in the slides. And 41.7% of them are with malignancy. Again, NPC is the most common one. 33% of the patients with acute onset dermatomyositis pass away within 4 years period due to cancer or complication. So what are the challenges that has been shared with this author? It's always small single center from one hospital. So that will lead to the question of, is that a potential biases? We are capturing a non-representative data for Malaysian populations. There are limited healthcare resources in Sarawak, including the specialists. That will hinder the whole process of diagnosis and making the diagnostic process delay. There is a significant diagnostic lag, as I said earlier, and there is also a limited diagnostic capability. There are few biopsies available with few local neuropathologies. Remember that to take the muscle biopsies, you have to do a testing. So it's really a challenge. And also, we hear this morning, there is also cultural factors. Back in Sarawak, the native populations in Sarawak often will look for alternative treatment before they come to the government or clinical. So when they presented to the hospital, it will be delayed. Then next one is Selayang. From Sarawak, we go back to Selayang Hospital. This is 2014. They are looking specifically on dermatomyositis and MPC. This is specifically analyzed because from the trend 1995 up to 2012, they are seeing a trend of DM and MPC. So now the Selayang team will focus on this issue. So they have included 21 patients from January 2000 to 2010. And 38% of them had malignancy. Of this, 62.5% is actually having MPC. So here they shows that we are seeing same things again and again from our publications. It's a male. In fact, it's dominating by Chinese as well, with a mean age of 50. 80% of them diagnosed with less than a year of dermatomyositis. This is their MPC profile. And then these patients, the DM-associated MPCs is having this EBV-related WHO type 2 to type 3 squamous cells carcinoma. So they are suggesting that detections using the rigid nasal endoscopy with biopsies or serum EBV IgA antibody and imaging will be very helpful for them. So here are some challenges reported. Again, small retrospective data set with non-standardized follow-up. Patients tend to default it. And they are missing of EBV, IgA testing. Therefore, they recommended to have a 5 years follow-up at the ENT to monitor the onset of MPC. So this is a review paper which Dr. Asro shared this morning from Terengganu. 2021, quite recent, from 2021 is a quite recent paper from Terengganu with idiopathic inflammatory myopathy. They have about 20 years data with only 15 patients captured retrospectively, and they do some descriptive study on this. 73% of them are female with a mean age of 44 years at diagnosis. 60% of them having polymyositis, 20% of them are having dermatopolymyositis. One thing we want to highlight here, I would like to highlight here is we don't see MPC. Finally, we don't see MPC here. But here also they did not mention about the ethnicity. Majority of the patients here is dominating by the Malay ethnic group. That's why we didn't see MPC. What we saw here is, if this is clear to you, those with more than 60 years old, they have some other cancer. What kind of cancer they have here? 47% of them have extramuscular manifestation, which is dysphagia, ILD, and also arthritis. So we did not hear so much on extramuscular manifestations in the previous paper, but now we are seeing this here. The ILD, the arthritis, and also the dysphagia. So interestingly, 27% of them with malignancy diagnosed after the diagnosis of dermatomyositis. From 2 to 4 months, they diagnosed with cancer. What kind of cancer they have? They have ovarian cancer, breast, colon, and also thyroid. We don't see MPC here. And 27% of them actually having overlap connective tissue disease, which is scleroderma and SLE. I think gratefully that corticosteroids are key treatment, and majority of the patients are still respond to corticosteroid. So these are some challenges that faced by This group of researchers, small and single, cohort leading to incomplete data, there are limited biopsy, and also MSA. Now, this is the first paper they specifically mentioned about myositis-specific antibody. The previous one, they only relies on CK or LDH. So it's a very basic or fundamental serology, which is not myositis-specific. Is that because of that we have underdiagnosed myositis? Some question that we should ask. And this group of researchers actually emphasize on long-term malignancy screening. They even suggest to follow up the patients from 5 to 20 years due to a strong associations and poorer prognosis. So this is all I have for the 5 most relevant papers in Malaysia up to 2021. I know that recently we also have some researcher published papers in related to myositis. It's from group, but I'm going to tell you more about it later on. It's a very special initiative that they have in So what is the key pattern across this study? This is something that I can summarize from all the publications that we have. It seems that there is a strong dermatomyositis and NPC associations in Malaysians, mainly on Chinese, male, less than 40 years old of onset. And IIM seems to be an early cancer indicator. The diagnostic gap or service gap here is we do not have access. Not everyone have access to electromyography, the muscle biopsy, and also the myositis-specific antigen. Only a very specific or tertiary hospital they can have. Even as now is the Selayang, the most tertiary hospital have to, no, the HKL have to send it to Selayang. So you see how are we going to do a research if this is not something that the infrastructure is inadequate for us? And then there is also a call for standardized the screening protocol. Like I say, we are lacking of, even we suspect of EBV, we suspect of MPC, but EBV testing is not available. So that is quite a number of challenges that we need to overcome. So what Malaysian study have covered so far? Clinical case series that we have been talking about for about 10 to 15 minutes ago, single-centered retrospective review. This is what the literature backbone is for Malaysian study. Several hospitals have published 8 to 10 years retrospective cohort describing the demographic, the clinical features, the cancer associations, and the outcome, and they are covered more or less the same pattern, mainly from HKL, mainly from Hospital Selayang, Hospital Terengganu, Sarawak. This is something that I get really amazed with them. They have the muscle biopsy biobank. Something that we can think of, how did they do it, and then can we calibrate for the clinicians, for those who are interested. So UMMC actually have this muscle biopsy biobank. They have been looking into the comparison of EMG muscle biopsies as to compare to the finding of MRI and also ultrasound. So they try to improve the diagnostic capability by introducing the non-invasive MRI and also the ultrasounds method. So moving on, this is what we have. If you see from the beginning, I'm showing you 5 subtypes of myositis. These are the 3 major ones that has been commonly reported in Malaysia cohort, which is the dermatomyositis, polymyositis, and immune-mediated necrotizing myopathy. And throughout the publications reported a multi-ethnic patients mixture with typical adult onset. It's only the first paper that we are seeing the one juvenile case. And cancer associations seem to be very common, especially for MPC. So in terms of diagnostic or investigations, this is some outcome. Like I mentioned before, muscle biopsies and EMG remain as a gold standard, even though now they try to move from this gold standard to MRI and ultrasounds for muscle inflammation mapping. And some of the centers, they also offer this myositis-specific autoantibody, and there is a need to standardize the diagnostic pathway across hospitals. So once we have standardized it, it will make things much more easier to address some question. In terms of treatment, the conventional immunosuppressions remain as a first line treatment, mainly on corticosteroid with steroid-sparing agents, which is the azathioprine and also the methotrexate. So the second line of treatment is more for second line of treatment is rituximab, and they are used for severe or refractory. Those are quite uncontrollable disease, or the ILD group. And then putting all this together, in Malaysia, our practice is actually consistent with the international practice, which is the EULA and ACR. But most of them describe in retrospective case series rather than the randomized trial. So if we come to this, we will say that multidisciplinary rehabilitations approach gains some attention because of the MPCs. More and more discipline have to come in to treat the patients with myositis and the associated diseases that they have. So the outcome or complications that have been reported is 40%, 30 to 40% of them presented with ILD. Infections being a major cause of morbidity. Malignancy-associated case show poor prognosis, and we have limited national registry that hamper our longitudinal outcome tracking. So what kind of research landscape we are talking about here? First of all, we have to focus on the area which is the autoantibody profile, the clinical outcome, and the malignant link. Currently, of course, there is enormous data on clinical outcome and malignancy, but we are lacking of autoantibody profiling. Next, to do this, we cannot do a single central study. So nowadays is no longer a single study. It will be time consuming and you will be exhaustive, and then you don't have enough patients to actually profile the characteristic. So what you have to do is you need multi-center collaborations, and if possible, we have to integrate with biobank, a myositis biobank or the muscle biopsies biobank. And as we can see now, here there are limited pediatric and juvenile myositis research in Malaysia. So again, I put it in another way. This is the key finding repeatedly. We are giving the talk repeatedly, and in the published paper, the findings are repeated also. So you can see here, the data reflect global trend with higher malignancy risk in dermatomyositis patients, and MPC is the most common cancers being reported. And then the finding supports that there is a need for routine cancer screening. In terms of antibody testing, we have to recommend a wider use of myositis-specific antibody, not to the tertiary hospital, but try to have it in more regional hospital. This I would not emphasize here. The testing access have to be made accessible to all centers if possible. And then in terms of diagnostic, now we have studies, they start to explore on muscle ultrasounds for IIM assessment. And we hope that some antibody tests can be complement to the enzyme testing, which is the CK or LDH, to strengthen the scoring. So how do we fit to the international picture? On one hand, we have aligned with the international idiopathic inflammatory myopathy guidelines and cancer screening recommendations, where we have the cancer link in DM, we have the diverse autoantibody profile and need for multidisciplinary. This is aligned with what the international have, but we also need a cancer screening and a diagnostic workflow. We have to seriously think of the diagnostic workflow. So putting all this research together, what is our strength? Where is our limitation? Our strength has been we are having so far all the real world data. We have multi-ethnic clinical descriptions, and we have attentions to the cancer associations related to local epidemiology, mostly on MPC. If we look into the publications from the Western, the pattern is not MPC. They have something else. They have ovarian, they have colon cancer and others, but not the MPC. It seems like MPC is quite common in our region, especially the Asians. And then the limitations that we have is so far is because we are mainly depend on the retrospective single study with small cohort. We do not have a prospective, a longitudinal, or a registry data to support our finding. And then there are few standardized or multi-center trial. Because of these limitations, recently the team in Penang, they have initiated a myositis for Hospital Pulau Pinang. They call it Myo Penang. But they are currently based on just one single center again. So just recently they have approved this retrospective plus prospective cohort. But then what the limitation, why they want to initiate this is because we know that internationally they have this Euromyositis or MyoNet registry for worldwide global, where they have about 16 centers from 20 countries, 20 centers from 16 countries have participated so far with about 6,000 patients. So in order for us to join them, we need to start somewhere. So that is why they have initiated. Then we hope that with the lead of Dr. Heng Mui Kim, the rheumatologist from Penang Hospitals, it can be expanded to more centers and become multi-centers collaboration. So these are some practical research and policy gaps that I have listed according to the literature that we have. First of all, we have to have our national or multi-center myositis registry. We need to standardize the myositis-specific antibody testing or the diagnostic workflow. And there is lack of multi-center prospective study. Now we are still at the era of single center cohort. And also we have to start thinking of the long-term outcome and also malignancy screening for our myositis patient. To add on this is We have also observed some resource limitations, especially the use of biologic, which is a very expensive medications or advanced treatments for this patient, which is rituximab, for example. And there are uneven specialist distributions, more on urban area as compared to the rural area. And in urban area, they are more concentrated in tertiary hospital as compared to primary or secondary. So that is our current challenges. The fragmented multidisciplinary practice here in rehabs and also care. If they have MPC as compared to myositis, I think the oncology or the cancer team will manage the patients because cancer is more, need more attention to them according to them rather than autoimmune diseases. And also we have say a couple of times about low public and also clinician awareness that cause a delay in referral. So we have a lot of challenges, but do we stop there? No. We should move on and see what kind of opportunity we can get from others, the lesson that we can learn and make up our roadmap here. So the roadmap here that I established, I put it here is 5 steps of our roadmap. Here is to establish a registry, start with 3 to 5 centers, if possible, to establish a biobank for these diseases, a centralized myositis-specific antibody or myositis-associated antibody testing, which we have now in Selayang Hospital, but we also hope to expand it, and the linkage to the cancer registry, to study about the high associations of MPC, the training and CME among the healthcare provider for early recognitions of myositis, and also to participate in the international collaborations, which is the MyoNet or using the IMET. Like I said, we have to turn the challenges to solutions. We never stop at challenges, we never stop at limitations. So try to turn this into the solutions. What we can do is a coordinated national framework can actually transform the Malaysian myositis research landscape, and investment in laboratory infrastructures, as I mentioned earlier, and the inter-hospital collaborations will be the key over the 5 years. So this is a few papers that I have referred to. I have exhausted the list, but this is what I have to share with you. Okay, with that, I will thank all of you. Before that, I will say that, okay, in order for us to climb to where we reach our goal and answer all the possible service gaps or research gaps, you need to set your goal, you need to make your plan, you need to get to work. If fail, you still have to stick on it so that you can reach your goal. And finally, I know this is something that we have presented last year. We have talked about rheumatoid arthritis. I have embarked on rheumatoid arthritis journey for almost 20 years. We have quite extensive sharing of how we work on this from scratch to where we are now. So maybe you can visit to our YouTube channel, and then you can see how we have sustained the progress in RA research, and hope that we can use it as a prototype to myositis research. With that, thank you. Makanan dah ada.
Are there any questions from the audience for Dr. Tu?
Alamak, bos kena tanya pula.
Okay, thank you very much, Dr. Tu, for very comprehensive. And I think we can see the future plan for Malaysian myositis research landscape. Can we go back to the slide before tu? No. Yeah, this one. This one. Next.
This one ke tak?
This one lah. This slide.
This one
Nombor 5 kan. Okay. This one very important for us because this is the roadmap for myositis in Malaysia that we should go forward lah if possible. So the first one, of course, we don't have yet, but the second one we already have actually. Centralized myositis specific antibodies in Selayang. The reason why Selayang because during that time IMR we don't have budget to offer the myositis specific antibodies. That's why when we discuss with the pathology KKM, we actually suggest that to have a dedicated center. That's why Selayang become the centralized myositis. So in other words, number 2 is already there. Okay, number 3, linkage to cancer registry.
Sorry.
Cancer registry, actually we already have cancer registry.
Yeah.
Only that how we want to link lah. That one we still not have the linkage yet. Number 4, I think this is the first national autoimmune seminar that we already put in YouTube. Hopefully all of us here can viral it. Maybe reach 1 million, then we can get okay. So after this there will be more lah, for awareness of this myositis. And lastly, the international collaboration. So all this very important lah, Dr. Siti. I hope can together with the other the university, Dr. Anis, together lah. Hopefully we can do this, Dr. Tara. You're very experienced in Manchester. Hopefully we can use it. Thank you very much, Dr. Tu. I don't have question. I just comment.
Thank you very much. Risau juga bos tanya kan.
Any more questions from the audience? If there are no more questions, thank you, Dr. Tu, for the amazing presentation.
Okay, thank you.
Now I would like to ask Dr. Tu to remain on the stage and invite Dr. Masita to present a certificate of appreciation to our speaker. Thank you again, Dr. Tu and Dr. Masita. Honorable guests, speakers, participants, ladies and gentlemen, we have come to the very end of the National Autoimmune Day 2025. On behalf of the organizers, I would like to thank everyone for your participation and support of this seminar. We hope everyone enjoyed and gained as much as possible from the event today, and we look forward to see you again in the future. Kind reminder to our online participants on YouTube Live, all questions posted will be answered by our speakers through email, and to our attendees here in the auditorium, please help yourself for some afternoon refreshment, which will be served over at Cafeteria Sehat Level 5. Last but not least, don't forget to fill up the feedback form by scanning this QR code that will be displayed later in order to get your certificates. Thank you everyone and have a wonderful week ahead. QR code. Hold on. Okay. All right. So scan this QR code to fill up your feedback form for us, and you'll get your certificate as well.